At the outset, I would like to welcome you all for this great scientific evening. Without wasting any much time, I would like to call upon chairperson for our first session, Dr. H.P. Singh, Dr. Ambuj Karn, Dr. Raksha, and Dr. J.K. Singh. I hand over the virtual platform to the chairpersons to proceed.
Uh, Very good evening to all of you. I think now we'll start this virtual meeting. Uh, this is related to and the topic is immunotherapy in lung cancer 2021, that is ever increasing spectrum. Very important topic. And friends, that lung cancer is a very fastly growing tumor, and it is very fastly increasing tumor also. In spite of the various advancements in the treatment in the lung cancer, overall survival was not very dismal. Today, lung cancer is not considered to be a single disease entity, but this is composed of several diseases conditional to histopathological types that determine the pattern of spread, treatment, and prognosis. Furthermore, the modern management of lung cancer requires more than ever conditions between all specialties involved in diagnosis and therapy. For the last few decades, in advanced non-small lung cancer, chemotherapy is recommended as a first-line treatment in patients with good performance status. The treatment objectives are survival, quality of life, and symptom control. Depending on the staging of lung cancer, patients are eligible for certain treatment ranging from surgery to radiation to chemotherapy, as well as targeted therapy. But due to various factors like resistance, the survival has not improved so far. And I think with the inclusion of immunotherapy in the management of non-small lung cancer, it has dramatically changes the scenario. Actually, immunotherapy has revolutionized the therapy landscape of non-small lung cancer, significantly prolonging the overall survival in advanced stage of patients. We have a very renowned speaker to discuss all the pros and cons of immunotherapy, and that is not other than Dr. Ulhas Batra, very renowned medical oncologist and a very big name in the country. I'm sure the learned speaker will enlighten us about all the details related to this new therapy. Dr. Ulhas, please.
Thank you, sir, for the kind words. I think my only best introduction is I work in an institute where Dr. Doval is the chair of medical oncology. So that is why we are all becoming big names in medical oncology only because of Dr. Doval.
True. That's true.
And so we are starting with, so I think I'm the opening batsman. And I've been asked to talk about immunotherapy in lung cancer in 2021, the ever increasing spectrum. And when I saw this topic for the first time, my first reactions on seeing this topic actually was the journey of immunotherapy in the last 6 years in non-small cell lung cancer. This was almost like a baby step that the nivolumab or atezolizumab took in the lung cancer 6 years back. This was immunotherapy in the second line non-small cell lung cancer. In 2014-15, this drug got approved. And now immunotherapy is like, you can't hide from immunotherapy everywhere. And the standard joke is that immunotherapy is going to become like a Packlet Excel. When in doubt, give Packlet Excel. So when in doubt, give immunotherapy. So you can't hide from immunotherapy in lung cancer, in stage 4 non-small cell lung cancer, in stage 3 non-small cell lung cancer, in resectable non-small cell lung cancer, also in small cell lung cancer. So these were my first reaction, and my subsequent reactions actually onto that were, अच्छा है, बहुत अच्छा है, because this is going to increase the survival, as Dr. J.K. Singh very rightly said, of patients with lung cancer. So let us look at the current status of immunotherapy in lung cancer. We divide this into non-small cell and small cell. In stage 1 or 2, there is no role at present. In stage 3, you can give RTCT and then you give durvalumab. In stage 4, we obviously have first line, second line therapy. In small cell, you have no role at present. In localized disease, extensive disease, obviously you have a atezo or durvalumab plus chemotherapy which comes. So let's see what is the evolving role of in 1920-21 with ever increasing spectrum. I'm going to slightly change the way I'm going to talk about immunotherapy in non-small cell lung cancer. Let's start with the stage 1 or stage 2 lung cancer, which was the uncharted territory actually. So let's start with evolving role of immunotherapy in resectable early stage lung cancer. We should always start with why. That why is it that immunotherapy is going to come into lung cancer in early stages lung cancer. Now, please note, this is a graph which I show over there. A 5-year recurrence by stage 1 was 45%, in stage 2, 62%, in stage 3, 76%. Now, contrast this with breast cancer, and you can actually feel, I always say, कि जहां ट्रिपल नेगेटिव ब्रेस्ट कैंसर खत्म होता है, एक अच्छा लंग कैंसर वहां से चालू होता है, and Dr. Dole will actually agree with me on that. So, in the benefit of surgery adjuvant chemotherapy or neoadjuvant chemotherapy, this was the advantage that was seen with chemotherapy, a 5-year absolute advantage of 5%, 4%. That is almost what CMF or AC gave to us in the breast cancer with the HR of 0.87, 0.86. So nothing very, very significant. What are the potential benefit from systemic chemotherapy? These will be patients who will be cured with local regional therapy alone. These will be patients who will have residual micrometastasis alone, who will not respond to immunotherapy, and the patients who will respond to adjuvant therapy are very, very minimal, just a very, very minute fraction of patients which actually will be there. So anytime, in the tumor board discussion, anybody asks you adjuvant chemotherapy, this is the typical medical oncologist reaction in the early stage lung cancer. Like, don't even ask me this, let's give it to something else. So definitely medical oncologists in lung cancer needed our help, and the immunotherapy in non-small cell lung cancer, we know it's like a bahubali. You have the Captain Marvel, and you have all the superstars which are there in stage 4 non-small cell lung cancer. So this is the current perioperative therapy paradigm, that you can either go for surgery or chemo and then EGFR TKIs, and you can go for neoadjuvant chemo and surgery after that. So where does immunotherapy fit in? Immunotherapy fits over here in after surgery chemo and immunotherapy, or neoadjuvant chemotherapy fills in with you give a perioperative immunotherapy alone, IO or IO chemotherapy. So I'll show you some data. This is neoadjuvant PD-L1 blockade and resectable non-small cell lung cancer. In 2018, this article was presented, and if you can look over here, neoadjuvant nivolumab, few side effects, did not delay surgery, induce a major pathological response in 45% of the resected tumors. If you look at this, the multiple other trials have been done. I think 6 randomized studies have been done. If you look at immunotherapy alone, you are basically looking at a stage 1, which or 2, which is higher in stage, 66%, 55%, 78%. A very important point is time taken to surgery has how many people have actually been taken to surgery have been very, very high. You have 100% of people, 92% of people which have actually been taken up for surgery. A PCR rate and a major pathological response rate of 10%, 15%, 33%. Now again, imagine a neoadjuvant AC in the CA breast gives you a PCR of 18%. But the major pathological response rate actually is to the tune of 40, 45% or 20% in some studies. Any biomarker which can be found out, unfortunately, PD-L1 and TMB, there is no biomarker which can find out has a correlation about which patient will respond or not. So this was about perioperative immunotherapy. Now it always takes, medical oncologists are greedy people. So can we do better? It always takes 2 to tango. So what about the combination of IO and chemo? We know IO and chemo are synergistic because chemotherapy, immunotherapy, there's an increased dendritic cells, increased trafficking of NK cells. There is increased infiltration of cytotoxic T cells into the TME. So 4 studies have been done. Checkmate 816, 671, Empower 030, EGAN study, which have looked at the PCR, EFS, and MPR actually over there. And again, you look at when you combine neoadjuvant chemotherapy, immunotherapy, you have a higher preponderance of the stage 3 disease, 77, 100, and 63%. Again, time taken to surgery is fantastic. Percentage of people who have gone to surgery 97%, 82%, 83% over here. So only, I mean, the surgeons will feel that, your patients will progress. That is something which is not there actually. People actually are going ahead for surgery. Look at the PCR rates, fantastic. 33%, 63%, 24%, and a major pathological response rate of 57%, 83%, 61%. That is something which is actually mind-blowing actually. Again, is there a biomarker? No, there is no biomarker. So which one to choose? I showed you data about immunotherapy. I showed you data about immunotherapy, immunochemo. So this is the summary over here. If you use IO monotherapy alone, you have 67% patients in stage 1 or 2, 33% in stage 3, a 23.4% major pathological response rate, and 7.5% of PCR. If you have an immunochemo, you have a 36.7% of PCR rate and a 64.7% of major pathological response rate. So if you have a T3 or a T4 lesion and you want response N1, N2, in that case, I will definitely prefer a IO chemo. If you have a patient whom you just want to optimize, an elderly patient, maybe a 4 centimeter lesion, a node negative or an N1 disease where you actually want to reassess for neoadjuvant immunotherapy and you don't want to waste time, probably in that particular case, a single agent immunotherapy in stage 1, stage 2 will be very, very okay. Now, let's come to the adjuvant side again. 4 studies again have been tried, the Keynote, the Empower 010, and the BR1.31. Again, look at the thing between the DFS and the OS. You will find out that, the primary endpoint in all these studies generally is the DFS and not really an OS advantage. Now, this study was published in ASCO 2021, where after 4 cycles of chemotherapy, we gave Atezo versus BSC. Please know, immunotherapy is not going to replace chemotherapy in the adjuvant setting, and the magnitude of benefit was much more higher with the Atezo with more than 1% PDL1. People who had PDL1 negative did not benefit. So if I have a stage 3 patient, T2, N2, M0, PDL1 more than 1%, I will definitely consider for a adjuvant immunotherapy after chemotherapy. But if I have a person whose PDL1 is negative, I may not actually consider for a patient who with adjuvant immunotherapy. So the role of immunotherapy in resectable, it is modest. Immunotherapy alone or in combination has shown efficacy. A high proportion of patients with the undergo surgery, and there is no correlation with PDL1 or TMB. Empower 010 has shown a DFS advantage. And I showed you a picture of a baby step coming in 2014. Now this baby is actually dancing over there. Immunotherapy is now dancing in non-small cell lung cancer early stages also. That was the evolving role of immunotherapy in stage 1, stage 2. Now let's look at the stage 3. We all know that if you have given CTRT to a patient and then you give durvalumab, there is a huge benefit. There is a PFS benefit with an HR of 0.55 and an OS HR of 0.71 with a 49% people living at the end of 4 years. Something which was almost unheard of probably 3-4 years back. So this is the standard. Now, can we do something better? So there are 3 ways in which immunotherapy can be used in stage 3 NSCLC. One of them is the Pacific way, that is you give CTRT and then you give consolidation. The next one is CTRT. You give new adjuvant CTRT and radiotherapy, and then you give with consolidation, which was the KN799 trial. And this was the KN799 trial, which actually used new adjuvant immunotherapy and concurrent chemoimmunotherapy with RT. And this trial showed that the overall response rate was 75% in the concurrent chemoimmunotherapy arm with the 6 months, and the PFS and OS was 87.2%. But this did not really set the stage on fire. The results are almost similar to what we got in the Pacific. Yes, it's a feasible one. Your grade 3 pneumonitis was seen in 9% of people, a slightly higher rate, nothing very great about it. So if you have to really ask me, how much do you give a neoadjuvant chemoimmunotherapy? I'll give probably at a 3 on 5 and nothing very great about it. So for the stage 1, stage 2, resectable, I'll give probably a 7 or 8 on 10. Now, what about stage 4 non-small cell lung cancer? And my first reaction when I was talking about newer strategies in stage 4 non-small cell lung cancer, are you kidding me? I mean, you have IO, you have a mini light IO, you have a CM227, you have chemo immuno. But please look at this, that even if you give a single agent immunotherapy to a person of PD-L1 more than 50%, your 5-year survival is only 32%. So you definitely need more support actually in patients of stage 4 lung cancer. There are many reasons that immunotherapy actually fails, which is basically, you know, the stromal barriers, the antigen loss, the T cell deficient activity, impaired antigen presentation, alterations in the interferon signaling pathway, and the future is exciting. A lot of bispecific combination, bispecific immunotherapy, epigenesis, chemo ADC have been used to find out, to prevent the resistance of immunotherapy. And this is one which is a TIGIT and a atezolizumab frontline, and this was compared. And look at this. This is your bottom line curve of a Keynote 24, and if you give a TIGIT plus a PD-L1 more than 50%, the curve is somewhere over here, which basically says 80% of your people are going to live beyond 1 year. But there was no difference in 1 to 49%. Another trial which had compared up lenvatinib and pembrolizumab and IO therapy, and again a fantastic report. We know lenvatinib and pembrolizumab is approved in endometrial cancer, so maybe this is also coming up in this way. So immunotherapy strategies in stage 4 lung cancer in 2008, immunotherapies are by and large looking similar. But whether in 2020 there will be a difference between Hrithik Roshan and a Harmesh Baweja, we don't know. This time only will tell. So that's a good question. Let's wait for the best answer over there. So I'll summarize. Evolving role of immunotherapy in lung cancer, early stage and locally advanced, massive progress as adjuvant and neoadjuvant therapy, locally advanced inoperable non-small cell lung cancer, small progress as concurrent CTRT, but no major gains in survival as yet. Stage 4 non-small cell cancer, we are already there, but no major progress as yet above the KN24 and the KN9, but there are exciting times ahead. Small cell lung cancer, it's a tough nut to crack. I think only Dr. Doval should be able to crack it. So I will end with this thing, immunotherapy in lung cancer. This is my favorite statement. You can love it or you can hate it, but you cannot ignore immunotherapy in non-small cell lung cancer. And there are miles to go before we sleep. This is my favorite slide. Hope was initially associated with breast cancer, but hope is now associated with lung cancer. And this is my latest favorite slide, that lung cancer deserves a cure too. So maybe in 2025, Dr. Doval, I'll invite you to chair a session on lung cancer survivors. Hopefully we both are in healthy condition to live to see that day. Thank you. Hand it back to the organizers.
Thank you, Dr. Vilas, for your excellent deliberations. May I invite my co-chairperson, other person, to take up the second topic, if they are here. Dr. H.P. Singh, Dr. Ambuj Karan, anybody they can take up? They are not here.
Yes, sir. So, namaste, Dr. Zaki.
Ambuj is there.
Yeah, I'm here. I'm having some.
Okay.
There's some internet problem at my side.
Second topic.
So, may I request Dr. Zaki to continue? I'm having some problem with my internet.
Then no problem. Okay,
Sir,
okay, then I will continue it. I think the next topic will be on the role of dual IO therapy in the treatment of first-line metastatic non-small cell lung cancer. Friends, as you know that immunotherapy is a promising treatment option for advanced lung cancer alone or in combination with conventional treatment like chemotherapy or surgery. It significantly prolongs the overall survival of advanced stage patients. Over the recent years, immunotherapy has been broadly integrated with the first-line setting, either in combination with chemotherapy or as monotherapy. With immunotherapy, the estimated survival rate improved significantly and the overall survival if compared with placebo group. Current FDA approval lung cancer immunotherapy drugs changed the treatment scenario. It was observed that 15 to 20% patients achieve durable result with immunotherapy. I'm sure our next speaker is Dr. Jyoti Bhadwa, and he's a very, very renowned oncologist. I request him to start the presentation on the second topic, that is role of dual IO therapy in the treatment of first-line metastatic non-small cell lung cancer. Dr. Bhadwa, Jyoti Bhadwa, please.
Thank you, sir. Good evening, everyone. So I'll be discussing about the role of dual IO therapy in treatment of first-line metastatic non-small cell lung cancer today. So this is how my presentation would flow. This is a BMS-sponsored session. We are all very well aware as oncologists that for treatment of advanced NSCLC, more treatments are still welcome. Almost 66% of all our patients do get diagnosed in stage 4 disease, and the 5-year survival rates are dismal 5%, though I would admit here that the results have definitely improved both in terms of quantity of life and the quality of life over past decade. So there is a great medical need to improve the quality of response, that is both the depth of response and the duration of response, therefore resulting in further increased long-term survival. So attempts have been on for many years and are still ongoing, and the advent of dual IO regime for treatment as first-line treatment of metastatic non-small cell lung cancer is a step in that direction, I would say. It is now US FDA approved, the dual IO based regime based on these two trials, the Checkmate 227 and Checkmate 9LA. Both these trials demonstrated a better chance at survival when compared with chemotherapy for first-line treatment of metastatic non-small cell lung cancer. The Checkmate 227 trial, the combination, namely Dutta with Yervoy, Nivo-Epi combination, has been approved for first-line treatment of adult patients with metastatic NSCLC whose tumors express PD-L1 1% or greater as determined by FDA-approved test without presence of any driver mutations. Based on the Checkmate 9LA trial, the Ipi-Nivo combination along with 2 cycles of platinum doublet chemotherapy has been approved for first-line treatment of adult patients with metastatic or recurrent NSCLC, obviously without presence of any driver mutations. Let's see how these immune checkpoint inhibitors work and how are they incorporated in this cancer immune cycle. So herein we are talking about 2 agents, namely the anti-CTLA-4 agent ipilimumab and the anti-PD-1 agent nivolumab. We all know that in this cancer immune cycle, there is first and foremost release of tumor antigens, which may be favored by chemotherapy, radiotherapy or targeted therapy also. There is tumor antigen presentation, and then there is T-cell priming and activation. So this priming and activation phase in this cycle is the earlier phase, and this is very important for the anti-CTLA-4 drugs to work on. Subsequently, there is trafficking of T cells to the tumor. There is T cell tumor infiltration. There is recognition of cancer cells by T cells, ultimately resulting in killing of cancer cells. Herein play the role the anti-PD-1 and PD-L1 antibodies. This is called the effector phase, which comes to play a role in later part of this cancer cell immune response cycle, and this is subsequent to the initial T cell activation. Now look at the 2 components of this IO-IO combination. Let's see the ipilimumab, the anti-CTLA-4 antibody. Now this CTLA-4 is expressed on the T cells and it inhibits T cell activation. So by using this anti-CTLA-4 antibody in form of ipilimumab, we enable adaptation to the evolving tumor, we promote emergence of memory T cells and cause compensatory increase in tumor PD-L1 as well. Therefore, there is some suggestion of synergism between these 2 agents when they are used together. Coming to the nivolumab component of the IO-IO combination, this is anti-PD-1. We all know that PD-1 is expressed on the tumor infiltrating lymphocytes and it's associated with reduced effector function. So by using nivolumab as anti-PD-1 antibody, we are in fact restoring or enhancing the pre-existing T cell response and increasing the cytokine production. Thus, there is a potential synergism when we use dual IO combination with CTLA-4 blockade and the PD-1 blockade. So the CTLA-4 blockade with ipilimumab blocks and results in distribution of activated T cells to the tumor sites. The blockade of PD-1 pathway with nivolumab results in target cell killing, the cancer cell killing, and inhibition of other pathways also, such as AKT, protein kinase B pathways, and it also prevents PI3K activation, the inhibition of that pathway as well. So this is the combination, and the first trial that I'm going to talk to you about in detail is the Checkmate 227. The 4-year update is now available. This is dual IO combination. This is a landmark phase 3 study that included patients regardless of histology. So both squamous and non-squamous NSCLC patients were included. They had to have stage 4 or recurrent NSCLC without receiving any prior systemic therapy. They were not supposed to have any known driver mutations, had to have good performance status, and PD-L1 expression had to be 1% or greater. The patients were randomized 1:1 into Opdita and Yervoy ipi-nivo combination, and the other arm was the standard platinum doublet chemotherapy alone without any IO drug. The treatment was continued until disease progression or unacceptable toxicity, or to a maximum duration of 24 months. Now, point to note here is that patients with untreated brain mets or carcinomatous meningitis, or those who had active autoimmune disease or medical conditions which preclude the use of IO drugs, were obviously excluded. The test for PD-L1 had to be a standard US FDA approved assay, and this was tested based on the IHC. So the median follow-up for Checkmate 227 is 54.8 months, which is the longest median follow-up of any IO-based combination in a phase 3 trial. Let's look at the two groups. The baseline characteristics, both the groups were very well matched. Also in terms of proportion of expression of PD-L1, those with less than 50 or more than 50 were equally distributed in the two groups. Now the results, what did they show? The combination was found to offer durable and long-term survival, with 29% of patients being alive at 4 years. Compared to 18% in the chemotherapy alone arm. So the median OS was 17 months versus 14.9 months with the chemo alone arm. And this is both the histologies included together. When we looked at the different subsets based on the histology, the non-squamous histology, the median OS was 19.4 versus 17.2 months, and the squamous histology, 14.8 months median OS versus 9.2 months in this subset with chemotherapy alone. So again, looking at the 4-year survivals, 32% were alive at 4 years in the non-squamous histology group, 20% in the squamous, and both these figures were remarkably better than the chemo alone arm. Now, when the patients were segregated and studied for those who responded at 6 months, it was found that 70% of these were actually alive at 3.5 years compared to 39% in the chemotherapy alone arm. So by looking at the responders at 6 months, a particular bias got avoided, and this also shows again that this combination, the dual IO combination, does seem to be effective when compared with chemotherapy alone. Now the overall response rate in the dual IO arm was 36% versus 30% in the chemo. The 4-year progression-free survival was 14 months versus just 4 months. Though the median PFS was not different between the two arms, being 5.1 and 5.6 months. the hazard ratio with the dual IO was 0.81 in the dual IO arm. Now, since I said in the beginning that attempts are ongoing to improve the duration of response, the quality of response as a measure of quality of response. Now, this Checkmate 227 trial showed that the median duration of response was 23.2 months with the dual IO Nivo-AP combination versus only 6.7 months with the chemo alone arm. So we see a huge difference there. At 4 years, 34% of the patients were maintaining this response compared to just 7% in the chemotherapy alone arm. So this trial did actually demonstrate the improved quality of response by using this criteria of duration of response. What about the adverse reactions? We are all very well aware that the IO drugs have their own peculiar set of side effects, and so was the case in this. So namely, the skin side effects, the GI side effects, the hepatobiliary side effects were seen as expected with the dual IO more when compared with the chemo alone arm. However, some patients did discontinue the treatment due to these adverse reactions also. But what was the efficacy in those who discontinued? So this is an interesting analysis which looked at the overall survival, the response rate and duration of response in those patients who had to discontinue because of treatment related adverse events. So in these group of patients, the median overall survival was still 30.6 months. 44% of the patients were still alive at 4 years, and the overall response rate was actually 35%. And the median duration of response despite discontinuation was 52.6 months in this subset of patients, again signifying that those who responded maintained their response for a significant long duration of time. So the NCCN guidelines have given its due place to the dual IO combination of nivolumab and ipilimumab as a first-line option for metastatic NSCLC across histologies, and in those who don't have any driver mutation and have no contraindication to the use of PD-1 or PD-L1 inhibitors and are in good performance status. So to summarize this Checkmate 227, at 4 years, the combination, dual IO combination continues to demonstrate durable long-term benefit when compared to chemotherapy alone. There have been no new safety signals. The 4-year OS is 29% versus 18% in the chemo alone arm. And 70% of responders at 6 months are alive versus only 39% in the chemo alone arm. So this dual IO regime is a novel chemotherapy sparing first-line treatment option for patients with advanced NSCLC. Coming to the second trial, the Checkmate 9LA, the 2-year update is available. This is a phase 3 randomized open label study comparing again Nivo-Epi. 2 cycles of chemo were included along with the dual IO, and this was compared with 4 cycles of only chemotherapy as first-line treatment of metastatic NSCLC. So adding 2 cycles of chemo had the basis that it could potentially provide rapid disease control while building on the durable OS benefit observed already in the Checkmate 227. So this is the study schema. The combination dual IO along with 2 cycles of platinum doublet chemo compared to 4 cycles of platinum doublet chemo. Again, the standard exclusion criteria as were used in the Checkmate 227, and the trial evaluated patients regardless of histology and again regardless of the PD-L1 expression. So this was different. So 2 differences, 2 cycles of chemo added and PD-L1 expression. It was irrespective of the level of PD-L1 expression. So what do we find? The median overall survival 15.8 months in the Nivo-Epi with chemo arm versus only 11 months in the chemo alone arm, the hazard ratio being 0.72. So again impressive results. At 2 years, 38% are alive versus 26% in the 4 cycles of chemo alone arm. Now, 37% of patients who were treated with the dual IO with 2 cycles of chemo were alive at 2 years, even though they had PD-L1 level of less than 1% versus 22% in the 4 cycles of chemo alone arm. Again, this combination, the IO with 2 cycles of chemo, the OS benefit was consistent across the various degrees of PD-L1 expression. So those who had less than 1, they benefited. Those who had more than 1 or 1, they benefited. And even those who had 50% or greater PD-L1 expression also had superior outcome, the median OS being 18.9 months versus 12.9 months in the chemo alone arm, the hazard ratio being 0.67. So there was a 33% risk reduction in the risk of death with the use of dual IO with 2 cycles of chemo. All the subgroups all the key subgroups on subgroup analysis seem to benefit with the dual IO with chemo, and at 2 years this combination nearly tripled the duration of response. The overall response rate and the median duration of, look at the median duration of response, it was 13 months versus 5.6 months only in the chemo alone arm. So 34% versus 12% at 2 years were still alive and responding. Again, no new safety signals were seen as expected with the combination. The incidence was more, but the side effects are often very well managed if we follow the guidelines and remain alert. So those who discontinued, again as seen in Checkmate 227, they still benefited at 2 years. 54% are alive versus 38% in the chemo alone arm. The median number of doses was 7 for nivolumab and 3 for epi, and the median duration of treatment was 4.4 months. So as I said already, the majority of treatment related adverse events did resolve through the well-established management algorithms if they were followed. So it's very important to be aware of the side effects, the timelines and the severity. So these are the various side effects, skin obviously being the commonest, followed by endocrine, GI and hepatic side effects. This is when compared with the chemo, it has its own set of side effects. So to summarize this trial, Checkmate 9LA, at 2 years the overall response was durable. In this combination, the benefit was seen across all the key subgroups, irrespective of the histology and the PD-L1 expression levels. No new safety signals again, and this trial demonstrated that nivo-epi combination with 2 cycles of chemo should be considered as new first-line treatment option for the advanced NSCLC patients. So this is the dose that was used in these 2 trials. The nivolumab used in 3 mg per kg, the standard dose, with epi dose of being 1 mg per kg Q6 weekly. In the Checkmate 9LA, it was fixed dose 360 milligrams Q3 weekly of nivo, with the epi dose being 1 mg per kg Q6 weekly, and the platinum doublet chemo in both these in this trial in both the arms of Checkmate 9LA was obviously 3. My last slide. This combination could be used as first-line treatment of metastatic non-small cell lung cancer, regardless of histology or PD-L1 expression, based on these 2 trials, namely Checkmate 227 and Checkmate 9LA. The results are impressive, and it's an important step towards improvement in the duration of response, durable responses, and in fact the quality of response in the treatment of patients with metastatic non-small cell lung cancer. So I'll end here, and thank you very much.
Thank you, Dr. Jyoti, for such a nice presentation. And I'm sure you have touched almost all the issues related to dual IO therapy. With this, we conclude this second topic. And now we have a panel discussions, and over to organizer to call the co-chairperson, if they have.
I think we can hand over the mic to Kumardeep because he was not there when we started the meeting, so that he can take on the things further. But Kumar, please.
Yeah. So, good evening, sir. Good evening, sir. So next session is panel discussion, which will be moderated by Dr.
Vikas Talreja.
Dr. Vikas.
Don't see. Dr. Vikas
Ravindra?
Talreja, please.
Sir, he's there, sir.
Sorry, Ravinder, is he here?
Yes, sir, Dr. Vikas. Dr. Vikas, please unmute. Sir, he just logged out due to some network problem. He's coming back in a minute.
Answer session with Dr. Jyoti. If there is any question to Dr. Jyoti, is she there?
Yes, I'm there.
Yeah.
Kumar, I'm there.
Yeah. Ajam ma'am, I just wanted to know what is your personal experience with the dual IO blockers?
See, I would admit that my experience is very limited.
Right.
The patients do have this, there are two constraints. One obviously is the financial constraint, and the other is the fear of the toxicities.
Right.
So that is still there in the minds of patients more than the oncologists, treating oncologists. But this, I think, dual IO has basis. There's a reason, as I mentioned in my talk also, there is synergism. The efficacy can get better with the dual IO combination, and the subset of patients who are wherein we have the option of using IO, say the group less than 50% PDL1 expression, therein this dual IO does provide us a chemo-free option. So that is where this could fit in. The synergism should be made use of, I believe.
Thank you, ma'am. Thank you. It was a nice presentation.
Thank you.
Kumar Vikas is there.
Yeah, Dr. Vikas Talreja. So I think you will call your panelist. Right?
Perfect.
Yeah.
Thank you, Dr. Kumardeep, for invitation. And I'm very sorry there were some power failures here, so that's why there was some delay. I must congratulate Dr. Kumardeep for an excellent meeting right now. I have been listening it for past few since 6 p.m. and it was definitely an enriching experience, especially Dr. Ullah's talk, Dr. Jyoti Wadhwas ma'am talk. Without any further ado, I would like to invite our panelists, Dr. Shifali Sardana, Dr. Sameer Purohit, Dr. Nagendra Sharma, Dr. Mudassir Ahmed, Dr. Kajal Shah, and Dr. Krishna Choudhury. I hope everybody is logged in.
Yeah, Dr. Vikas, I'm there, but I am driving, so bear with the intermittent issues. I'll be there.
Not an issue. So we'll be just discussing because this topic is definitely a wide topic, and I think we need a 1 week conference dedicated to what is the first line strategy for the metastatic non-small cell lung cancer. But still, to strategize, what we need is those systemic strategies, because we have seen a lot of paradigm. Earlier, people used to fancy smoking, then people came to know that no, smoking kills. There are advertisements which still says that smoking was a recreational experience, but when people tend to knew the side effects for it, and before this would be much more interactive talk, because we know we have been discussing the lung cancer extensively over the last few months, specifically with the each and every day the number of the topics that are coming, the number of the targets that are coming. So the first case I would like to start with: 65-year-old male patient. He visits to the OPD with complaints of breathing difficulty, chest discomfort, with 35-year-old smoking history. X-ray confirms this. A CT reveals a mediastinal adenopathy, 4 liver lesions. Biopsy consists of the liver lesions consist of adenocarcinoma lung. Now, to my panelists, these are the tests that I would advise on upfront, based on probably the coupon that is available to me. So for all my panelists, if finances are not in restraint and finances are restrained, what would be your first strategy for the mutation testing? So Dr. Samir Purohit, the first question goes to you. Would you do a more panel, or you would restrict to this panel, since these are right now the first line strategies which you want to direct to?
Sir, sorry, Dr. Samit could not join, sir.
No problem. Dr. Nagendra Sharma is there?
Right, sir. I'm there, sir.
Perfect.
So I just want to bring it to the notice of all the audience that whenever we are having adenocarcinoma, which is confirmed histopathologically, first of all, we should encourage patients to go ahead with NGS, Foundation 1 NGS, because there are a lot of merits for that if affordability is not an issue. The only hurdles which I think is the turnaround time and the cost which is involved. If affordability is not an issue, and if turnaround time is not an issue, I think we should always open up the discussion for comprehensive genomic profiling by NGS. And if affordability is an issue, then if the coupons are available the way you told, so what is mentioned in the slide, I do agree. EGFR, ULK, ROS1, BRAF, and PD-L1 also, with the standard platform, we should go ahead and take the action accordingly.
So a counter question just for academic interest, sir. If the EGFR comes out to be positive, do you think you would see the EGFR ALK ROS right now is by coupon, and considering the Indian circumstances, or probably if finances are not an issue also for the patient, EGFR, do you want it by the standard, the coupon, the NGS testing, or by right now the PCR testing, when it is available in 4 to 5 days of turnaround time? Or you want to wait for 14 days or 15 days for that Foundation 1 test report to come to say that it is EGFR positive? So you have probably wasted 10-12 days more of the patient for the same EGFR report. Again, for academic discussion, what would be your preference? That first we should do a limited panel and then go for a broad panel if the limited panel comes out to be negative, or you straight away would go to the broad panel to avoid the tissue wastage?
Right. So it's a very good pertinent question which you asked, which all of us encounters in our clinical practice. The first point I want to bring it to notice that it depends on where you are practicing. If you are practicing at a tertiary care center where in-house testing is available, always go for that. If you get your more common, in oncology, if you think of common things first, you will be commonly correct. And if you think of uncommon things first, you will be uncommonly correct. That's the way dictum is. So upfront, in-house testing is available. Go ahead with this test. If the report comes out to be positive, go ahead with and take action accordingly. Suppose if the patient is having an oligometastatic setting, patient is not sick, female patient, in more likely chances of getting mutations are there. Then if turnaround time also is not an issue, there's no hurry of starting drug, I will go ahead with comprehensive genomic profiling and find out what mutation is occurring, and there's a merits for that. But if turnaround time still patient is sick, I want faster reports, in-house testing is always preferable. It depends on circumstances where you are practicing and how patients you want to unfold the treatment.
Dr. Mudassir sir, the ball is in your court right now. The patient has knocked up to your feet. He has taken a second opinion from you. Dr. Nagendra sir has said that, no, I want the best of the testing. I want the Foundation 1 to be done. The patient thinks that he can't wait for 14 days. He comes to you, and now what's your take for that?
Okay, so I agree. First, I agree with everything what Dr. Nagendra has said. So my attitude is also the same, that we should be doing the broad-based testing, because see, nowadays the biggest decisions we have to take in patients is whether to go for chemotherapy plus immunotherapy versus go for targeted therapy based on the mutation, isn't it? So if I have to go for immunotherapy plus chemotherapy, I would definitely need not only EGFR, I would need ALK, ROS, as well as other mutations. So my problem is not only solved by a single EGFR. So if it was such, then I would probably go for an EGFR and then decide whether to go for immunotherapy or not. So my problem will not be solved by single EGFR gene mutation. So that's why I would like a broad-based, NGS testing. And at the same time, if I feel that the patient is very, say symptomatic, and I feel that something should be done quickly, I would suggest go for a bit, maybe a cycle of chemotherapy, till the time we receive the testing. Otherwise, I would wait for the NGS report.
Wonderful, sir. Dr. Shifali ma'am, do you like to agree with the same, or you want to differ while you drive?
Dr. Vikas, I'm so sorry.
Dr. Vikas.
Dr. Samit has joined, sir. I'm so sorry for interruption.
No issues, no issues.
Right. So my take on this would be like, it will depend more rather than cost. It will depend upon more of the tissue availability. So if we slice the tissue for each and every investigation separately, like EGFR with PCR, then ALK and ROS with FISH, and then PDL1 by IHC, you are losing the tissue. So if affordability is not an issue, like you said, okay, NGS is every time preferable. That is a separate argument whether we go for foundation versus any other. But of course, NGS is preferable. But otherwise, deciding upon immunotherapy versus EGFR, I think in the first go, if patient cannot do a NGS, so doing a EGFR, ALK, ROS, and PDL1 would suffice, I think. And BRAF, of course, in the first level panel.
Wonderful, ma'am. So we have Dr. Kajal Shah with us. Now, the same patient comes to you, and he is like Ambani of all the traits, and he says that I can afford whole exome sequencing, and I want to just change the gear to another level. So, Dr. Kajal Shah, is she there?
Yeah.
Perfect.
So we generally, means affording patient, we advise the next generation sequencing. In NCCN guideline, there is a discuss about the prognostic marker also. If patient have some KRAS mutation, then is indicate of a poor prognosis. So we can also do NGS to detect what is the prognosis of the patient. And we can find out the all type of the molecular marker.
Hello, मैं call back करता हूँ. Dr. Krishna Choudhury, again, so a whole exome sequencing probably would give you much more information than probably the NGS testing, especially the broad gene panel testing, rather than vis-a-vis a limited panel testing, vis-a-vis a fixed EGFR, ALK, ROS. So what would be your preference for the same, for the patient with the upfront metastatic non-small cell lung cancer? Dr. Krishna Choudhury, is he there? Not an issue. Dr. Purohit, sir?
Yeah, hi. So my preference would be for a broad-based panel upfront if the patient is affordable. As of now, in my practice, I am restricted to a few hotspots only: EGFR, ROS, BRAF, HER2/neu. But in the continuum of care which we are into, and I think a broad-based panel is the way for future. And so somewhere down the line, we'll be ordering it upfront, and that would actually help us to decide the medicine right now, and probably gain some knowledge about the other patients also, like the incidence of different genes which we'll be seeing. Like we know we are experienced with the incidence of EGFR, ALK, ROS now, but for other genes, I think we still need some experience. So with time, ordering a broad-based panel upfront will actually help. And if you see the whole the NSCLC bulk, close to 62% of the patients will harbor some sort of mutation, even though we don't have actionable drugs for all of them right now. But actually, the broad-based panel should be the way ahead, what I feel.
So just one simple question to you: how broad is your broad-based panel? So do you want those 5 genes? You want those 512 genes of the foundation one, or you want the whole exome to be read in the first go only, so that any possible target, if there it is, you don't want to miss out?
So if possible, the whole sequencing is what is required for me, if I can do and the patient can afford. Otherwise, for my current practice, I am restricted to major hotspots only.
Wonderful, sir. So again, the tissue has been sent for a broad-based gene panel testing, as all my panelists agreed that we would love to have as many targets as possible. Meanwhile, the patient is symptomatic and you want to give him some sort of therapy. So we have seen that $1 million subgroup analysis, which gained probably the Lilly blockbuster Alimta. Now, would you go beyond and add something to it? You want to add the IO before you get the target, or you want to add the bevacizumab to the combination? So first question again to Dr. Nagendra, sir. Dr. Nagendra?
Unmute, please.
Hello, sir. Whether I'm audible?
Yes, sir.
Yeah.
You are.
Right. So in this type of scenario, sir, when we are not having the reports of whether patient is having PD-L1 positivity or not, or whether the actionable targets are not there in front of us, in that case, I will be happy to use pemetrexed plus carboplatin rather than adding bevacizumab. Yes, there is data which you just mentioned in the slide, but I'll be happy to use with doublet, because there are some side effects which are also associated with bevacizumab, and of course, the cost also will go up. So there are limitations to that, but I'll be happy to use doublet platinum-based chemotherapy upfront till the reports are ready.
Dr. Mudassir, you have a change of heart, or you would like to offer more, or you would like to continue the same?
So I would continue. I would do chemotherapy only. I would not add any additional agent, since I'm still waiting for the targetable, I mean, say the mutation testing. So
wonderful.
I would like to be minimize, because all these agents like immunotherapy will not help in those those 20 to 30% are, let's say 20, 30 or 35% who will be having a mutation. And the bevacizumab benefit is mostly seen when it is used in maintenance. So both are in jeopardy right now. So I think no.
Wonderful, because the patient says that I can afford anything, let the report come. But then again, I have all the means. I want the symptom to be resolved right now, and that's what my primary concern is right now. So moving to Dr. Kajal, would you also agree with the same, that you would not add the IOs or the bevacizumab in wait for the chemo for the mutation report to come?
In our institute, we generally give platinum doublet with pemetrexed in a patient when come to the emergency while waiting for molecular testing. We don't give immunotherapy in performance status 3 or 4 like patients.
Very well said, ma'am. So, Dr. Shefali, ma'am, the ball is in your court. The patient has visited all the centers, and right now he's very anxious that I want the best of the care. He has read all the Empower studies. He says that yes, even if it comes out to be EGFR, some immuno is going to benefit with the combination of ABCP combination. So would you do ABCP combination while the patient awaits the report for the biopsy, or you would say no, I would wait for that report, I will give the platinum benefit and then see what's the take for it?
All right. So my decision making would be based on number one, what is the quantum of disease burden? And if I expect, say, another 3 weeks for the report to come, suppose affordability is there and we have sent the foundation one, so another 4 weeks. So I would judge the disease quantum burden. If it is too much, okay, I would offer the patient a platinum-based chemotherapy if I see an impending crisis, or if the patient is symptomatic. So in these conditions, I would start upfront chemotherapy, wait for the NGS report. Of course, I would not add any IO or any other combination till I have that NGS report. See, my all-purpose purpose of doing NGS is to find a suitable target which I can identify and target upon. So there is no point doing mix and match till I get the report. So I'm clear about that, and rest depends upon the counseling, how we counsel the patient. Okay, you have all the word available, but you can't go for everything whenever desired. So that is my take on it.
So disheartened patient goes to, he was looking for much things. He goes to Dr. Samir Purohit, sir. And
Hello.
would you, hello? Dr. Samir Purohit, sir, would you like to just agree with the panel, or you would say, no, I think the Pembro or the ATZ combination would definitely be beneficial for this patient with liver lesions, with lung mass? Dr. Samir Purohit, sir.
No, I don't give immunotherapy upfront unless until I have all the reports with me. I usually tell patient, if you are symptomatic, if you have a disease burden, I'll start with chemotherapy. If you can wait, the symptoms can wait, then I'll ask him to wait. Let the reports come and then I'll start therapy.
So wonderful panelist to me that yes, we need to target those targets. Until that time, only the symptomatic care is essential, because we see that the reports across that people tend to have what we see, that the targets, if they are there, giving a targeted therapy to the target is always beneficial as compared to just giving all guns before, because they have their share of side effects and we need to look forward to it. So right now we have those driver alterations as we see, and out of these testing, how much do we do in our clinical routine practice? Dr. probably Nagendra sir. So out of these testing, which you specifically do for a clinical practice for these patients? So Dr. Nagendra, sir?
Right. So the most common test which we are doing is EGFR, ALK, ROS1, PD-L1, BRAF. And if tissue is not an issue, I will go ahead with the other uncommon mutations like CMET, exon skipping protein mutation, RET, and if possible, NTRK. So these are the common tests which we are doing because they are a suitable target for that actionable mutation, and we can take up. We'll be happy to use targeted drugs for these patients. And if nothing comes out, then I'll be happy with doublet platinum chemotherapy.
Wonderful, wonderful. So we definitely tend to agree with the same, because everybody, I believe, would be targeting the same targets right now to find out those targets. And it is important that our Indian histology is definitely a different mutation wise driven also, because this was the paper that we co-published during our time while I was in Tata, with the EGFR mutation. In Indians, the incidence is around 23%, and we do have a lot of FGFR mutations in contrast. So if we look at the mutation profile of the Indian patients, this is what was published. The FGFR rate is around 5.5% as compared to the traditional 3% across the subgroups. And the EGFR, we do have 28% as compared to the East Asians, where it is around 40 to 55%. And in Europe, where it is 5 to 15%. And that's our subgroup. So now we go and we look out for the same patient. Now, since it is a very limited panel I have right now, and would directly take each of these mutations as separate. So first to Dr. Mudassir sir, the patient comes out to be EGFR positive. The options are in front of you, and what would be your preference of agent for the same patient?
Yeah, if we go with the same, I mean, say the tagline that the patient has no financial issues, then I would go for the osimertinib for EGFR positive, metastatic lung cancer, and I would use the osimertinib as the first line. But if there are any financial issues, or after discussing with the patient that we can just do a second generation, that is dacomatinib or afatinib, followed by osimertinib. then it will be a very close discussion with patient. But other than that, osimertinib is the easy choice, less side effect, covers almost everything. If the patient is EGFR mutation, is the typical exon 19 deletion or exon 21 858R. If there is anything else or like 858R, I may use I may discuss dacometinib or afatinib in case of del 19. But probably, if I do not have to think about the mutation, osimertinib is my first choice. But if there are uncommon mutations, then I would certainly go for afatinib.
Very wonderfully said, sir. Dr. Shefali, would you agree with the same, that EGFR mutation, you look only at osimertinib, or you want some discussion along?
So if we see with the good data, so we have two drugs available with us, osimertinib and dacometinib, both good data. Though Archer could not come into usual practice because osimertinib was launched first, that was separate issue. But of course, osimertinib is very well on cards, need to be discussed with the patient. Once you have such a wonderful drug with CNS response, with everywhere else response and OS data, of course, osimertinib is the preferred choice. If not, then dacometinib or uncommon mutation like Dr. Mudassir really pointed out, or L58R, I would prefer afatinib in that case. And in case of even non-affordability, they can discuss about afatinib or other generation TKIs. That would be my.
Very well said, ma'am. So, Dr. Samir Purohit, sir, would you agree with the same, that EGFR mutation osimertinib is the drug of the choice unless and until proved otherwise?
I agree.
Wonderfully said.
Osimertinib is very well tolerated with good CNS penetration, so I would go with osimertinib.
Dr. Kajal Shah, would you also agree with the same, that yes, I agree with that? EGFR, my reflex decision is to give osimertinib if I'm not looking at the pocket.
Yeah, definitely. We use osimertinib followed by dacometinib and afatinib.
Wonderfully said, then. Is Dr. Krishna Choudhury joined right now? Not an issue. So we have a consensus of opinion that yes, EGFR mutation, we do osimertinib because of the rich flora data and the OS benefit it has right now. Now comes the best part of it. The patient comes out to be ALK IHC positive. So again, Dr. Mudassir sir, over to you. Would you like, what out of these four options and the lorlatinib right now would you like to give for the patient? Dr. Mudassir sir?
I was muted.
Okay.
So I would like, if again the finances are not the issue, so I would like alectinib in the first line, and then kind of keep everything later. But if there is finances are the issue, then I would go for crizotinib.
Very well said. So your first preference is alectinib for the patient, and next to Dr. Nagendra sir, what's your take on this, that finance is not an issue, ALK IHC positive, your take, alectinib?
Yeah, I do agree with Dr. Mudassir. The alectinib is my treatment of choice in ALK positive NSCLC's adenocarcinoma. It's having a better survival benefit, and it's a godfather of all ALK positive TKIs. I'll put it like this.
Very well said, sir. So any difference of opinion, Dr. Shefali ma'am?
So again, if we go with data, so alectinib is on cards, definitely. Lorlatinib, yes, but lorlatinib, I literally look upon if someone fails the first line. So I do agree with the previous speakers. So reserve my cards on that.
Dr. Samir Purohit sir, you also agree with the same?
Victo.
Okay, perfect, sir. So
may I ask something, Dr. Vikas, if you allow me?
Sure, sir. Please, sir.
So one interesting scenario happened with me, which is I just want to share. I won't take more than 30 seconds. That one patient was brought to emergency in a very poor performance status, directly intubated, female patient, non-smoker, and we were not able to do tissue diagnosis from the lung. But when we assigned liquid biopsy, ALK came out to be positive. So are we medically legally justified to start TKI in this type of scenario when the tissue diagnosis is not there and patient is having ALK positivity with a lung mass?
So the benefit of the moderator is that he doesn't have to give the answers, and I would redirect the question to my esteemed panelists. So the same question, yes, I would say that if not for say ALK positive, also the EGFR, ROS, or BRAF, the mutations that are in front of you. Many times we face with the scenario that the patient declines doing a biopsy or FNAC, and then you tend to do an liquid biopsy, and you find out these mutations which you want to hit upon. Have you started, or would you do such things of starting therapies based on liquid biopsy reports without the biopsy, or probably the same? So Dr. Shefali ma'am, first to you.
Yeah, so very interesting and practical scenario. So one thing I would like to confirm, okay, whether we have done this liquid biopsy pe ALK positive. So I would like to start. Because I know the patient is anyways going to go if intubated if we don't do anything. This is a fair trial to try. Simultaneously, after starting, I'll definitely try to do a tissue diagnosis if that is feasible to confirm. But otherwise, I think we should give a fair try. From my side, I would do that.
So Dr. Samir Purohit sir, also we will not be recording. I request the organizers not to record, because then it becomes slightly medical legally improbable. But we do definitely face with similar issues once in a while, that the patient is intubated, very sick. You find a mutation based on the liquid biopsy, and you want to hit upon that. So would you do on immediately by the Ryle's tube? Would you give any of those TKIs, or you would say no, I will wait for the histopathological report and then only I will hit upon?
No, I would start. I would counsel the patient's relatives and I will start.
Very well
But I
said.
would definitely confirm it with a biopsy later, but I would start.
Dr. Kajal ma'am, would you also agree with the very interesting scenario that has been put forward to us?
Yeah, I will confirm it is a metastatic disease or only this localized disease.
So the patient is intubated right now, bilateral, let's say lung nodules are there or whatever. The patient is in any case right now on ventilator. So
Dr. Vikas, I have a submission here. So if the patient is on ventilator and we have somehow started and the patient has improved actually, so do we really need to do the biopsy? You have seen the patient improving on an ALK inhibitor. Why do you need to do a biopsy then?
no, sir. But then at the end of the day, we
Yeah, I agree.
are answered on paper. So that's why I said I won't record this for the session. But yes, we tend to do all these stuffs off paper. And that's what I wanted to ask, that what we do offline, is it justifiable? So Dr. Naginder, so you have asked the question. I would say
I just want to I don't want to complicate the discussion, but the point here is ALK positivity is not only seen in lung cancer; it can be seen in some other cancers also. So until we are having a FNAC or a biopsy tissue, we should not jump into starting ALK. This is not medically really correct, but yes, one can argue that the patient is sick and we have tried for whatever benefit. But medically, my question was whether it is medically correct.
So, Dr.
Right.
Nagendra, sorry to interrupt. I would like to mention, whatever tumor is ALK positive, ALK inhibitor generally work. Number one point. Number second, your radiology would generally give you an idea whether it is a probable lung cancer or something else. So even if you are suspecting any, say, any of the tumors in which ALK is positive, generally ALK inhibitor do work. And this is the only chance where you can retrieve back because they work beautifully. So I think medico-legally, if the family is counseled and you can put down on paper that there is a limitation to do a biopsy in her case and there is a liquid biopsy which is fairly suggestive. I agree in other cancer liquid biopsy is not validated. So, but that is a R and par game. I think if the family is counseled, there is a worth trying. I agree medico-legally issues may be there, but if you can document it properly, I don't know how to go about it.
I think everybody has a story on this, to start treatment without the final report. So I don't have an ALK story. I have an EGFR story. I think there are tons of that already there. So we had a patient who was very sick. He was at that time, I think 76 years old, and he was quite sick. And he was shifted to the ICU, and the patients, the family said that no, we don't want to go for a ventilator, etc., etc. So he was shifted back to ward. Fortunately, we had done some FNAC or biopsy before, so it came out to be adenocarcinoma. It was a non-smoker. So we counseled the patient, family, and we said that there are some tape tablets available, etc. But we'll be doing that after the tests are available. But then they said that can we start it now? So we started gefitinib, which was quite easy, available, low cost. We thought that the side effects are also not too many. We started it. Later on, the patient came out to be actually EGFR positive, but patient went on to live for 2 more years after that. And I think these stories are everywhere, but is it medico-legally advisable? I think whatever is done in good faith and with some science behind, you can explain it. It does not need to be FDA approved always. But at the same time, I would say that it has to be after a proper discussion with the family.
I totally agree, because at the end of the day, we are treating patients, we are not treating reports. And that's why it is very important that we should be keeping everything in our mind, that at the end of the day, even if the patient comes out to be EGFR positive with a dead body or with ALK positivity with a expiry, we would be feeling much more worse than we could have, because and to counterpart, Dr. Shefali ma'am had certainly said that yes, it is very important that we do only liquid biopsies when we are thinking of lung cancers. If we didn't have done a liquid biopsy thinking of the lung cancer, we wouldn't have advised it. So Dr. Nagendra did have a justification for it.
Dr. Vikas, Kumardeep here. We are running slightly late.
So only 2 mutations to be discussed in quick go, because I won't be taking those data because it has already been discussed. Dr. Mudassir, BRAF V600 positive, your drug of choice.
So though this dabrafenib trametinib is there, so but I most of the times use chemotherapy in the first line and then go for the dabrafenib trametinib combination in the when they fail. So for V600E mutation, yeah.
Dr. Samir, I saw Dr. Shefali Sardana.
Yeah.
Tomorrow
So
Netco
again,
launches. Just a second, ma'am. Just a second.
Yeah.
Tomorrow
Sorry.
Netco launches encorafenib and binimetinib combination. You have dabrafenib trametinib already by a company, and you have a chemotherapy that is suggested by Dr. Mudassir. So the patient comes to you, and now what's your take of call?
All right. So wonderful. So again, my submission, I have not used BRAF inhibitors till now in any of the patients. So for me, either of the choice on cards is there. Okay. And the second thing is, my take on BRAF inhibitors would go on what is the CNS burden of the disease, how symptomatic the patient is in CNS, and the other disease burden. So if the CNS disease is too much, disease burden is there, BRAF V600 anti-BRAF inhibitors is my choice. Otherwise, I have 2 options, either to go for BRAF inhibitors or for immunotherapy for that purpose. So IO combination very well works in this mutation, and then anti-BRAF, though we know. So my choice would depend upon such kind of thing. So I would go for dabrafenib trametinib combination. It is available right now. I mean, people have used, and I have their experience actually, rather than the encorafenib and other binimetinib. So that is how I would decide.
Dr. Vikas, I have one point to make. The immunotherapy works very fine in the BRAF mutant patients. And I think and in the immunotherapy we have a kind of possibility of CR. So probably immunotherapy may be favored over the targeted therapy in the first line. So, but
so I would like to differ in this case, because there are good response rate, but no for now because there are no level 1 indications. And second, across whatever be it, the PF is very less. So till the time we have a very good data right now, probably IOs would not be justified right now in BRAF V600. I will show you a table just in future before I end the session, that IOs are not that much effective as compared to, as we extrapolate the melanoma data, but no, it's not the similar in this case with the lung cancer with IO and BRAF V600 positivity. I don't think so. We have Dr. Samir Purohit, Dr. Nagendra sir.
Yeah, I do agree. I'm having one hands-on experience, but that was a post-osimertinib progression. I got one of the patient who got BRAF V600 fusion rather than BRAF V600 per se. So in that case, we started this and it worked, really worked. So ideally, if you get the BRAF V600 mutation, definitely dabrafenib imatinib is an excellent combination. Only thing is we have to manage the toxicities if at all any, but this is a viable option.
So definitely a very good option. As I said that, yes, if availability is not an issue, we would like to give the best possible combinations. Now, just to end the talk, last 2 minutes, the patient comes out to be ROS positive. Dr. Mudassir, what's your take for it?
So I think we may give the patient the benefit of crizotinib. So ROS, we have good agent available. They respond usually well. So crizotinib is my choice.
Dr. Shifali ma'am, would you also agree with the same?
Hanji, I would agree. Yes.
Perfect. Dr. Nagendra sir, also you would also like to agree the same?
I do agree. I do agree, sir.
So that brings to the kind attention for everybody. I would like to give the show to the organizers. Thank all the panelists, Dr. Kumardeep, Dr. Shifali, Dr. Samir Purohit, Dr. Nagendra, Dr. Mudassir for a very important topic that in lung you have to hit as fast as possible and as deep as possible with the best possible targets available across, so that the patients gets the best possible outcomes with the science that is evolving to it. Over to Dr. Kumardeep sir for.
Thank you, Dr. Vikas. Thank you for giving your time on Krishna Janmashtami evening, and you have grilled your panelists well. Thanks, Dr. Shefali, Dr. Samit, Dr. Mudassir, Dr. Shah, Dr. Nagendra Sharma. Thanks, Dr. H.P. Singh sir, Dr. Ambuj Karan, Dr. Raksha, Dr. Jackie Singh sir, who have chaired the session. For next session, may I call Dr. D.C. Doval sir. He is my guru. He is guru of many oncologists who are practicing across India. And another senior oncologist, Dr. Ramesh Nimagadda sir. He is Chief of Medical Oncology at Apollo Hospital, Chennai, and Managing Trustee of Ramesh Nimagadda Cancer Trust. Dr. Doval sir, Dr. Ramesh Nimagadda sir, and Dr. Rajesh Vashish sir. He is Director Radiation Oncology at Max Batinda, and he is also President Association of Radiation Oncologists of India. Dr. Sudeep Srishta sir, he is Executive Chairman and Senior Consultant at Nepal Cancer Institute and Research Center, Kathmandu, Nepal. Doval sir?
Yeah.
Dr. Ramesh Nimagadda sir, and they will be chairing the session on breast cancer.
Okay. I think Dinesh, are you going to start?
Dr. Please unmute.
I'm trying to get the program.
Dr. Doval, please unmute yourself.
Dr. Ramesh?
Yes, okay.
You can introduce the speaker.
Okay, sure, fine. Yeah, we'll start off with this. It's an important topic, as I see lately everywhere. This is the only topic being talked in breast cancer and hormone positive, HER2 negative. And the first talk is going to be by Dr. Jyoti Anand, and it is evolving strategy in management of ER/PR positive, HER2 negative advanced breast cancer, to set up the stage for the panel discussion. Dr. Jyoti.
Hi, good evening, sir. Thank you, Dr. Kumardeep, sir, for giving me this opportunity. So can we have the slides, please? So today I have given the responsibility of discussing the evolving trends in the treatment landscape of HER2 positive and hormone receptor positive and HER2 negative advanced breast cancer. So as an oncologist and as a patient, what we actually need is what is our first goal, treatment goal is overall survival. So when considering the options for metastatic breast cancer, overall survival is our primary treatment goal. Achieving a statistically significant difference in OS in hormone receptor positive HER2 negative metastatic breast cancer, it has been a challenge. In nearly 25 years, 5-year survival rates of hormone receptor positive HER2 negative breast cancer may have improved. Over the past decade, few studies with targeted therapies have reported statistically significant improvement in overall survival. With the challenges in achieving overall survival in metastatic breast cancer, PFS has become a clinically meaningful endpoint for metastatic breast cancer trials. However, improvements in PFS have not consistently translated into OS benefit. So achieving an OS benefit may be difficult, especially in earlier lines of therapy due to several factors, including receipt of several lines of subsequent therapy leading to use of endpoints such as PFS. As with other targeted therapies, improvements in PFS seen with CDK4/6 inhibitors have not consistently been linked to an OS benefit. So despite challenges in achieving OS in MBC, Prixana has shown statistically significant improvement in OS across 2 phase 3 trials. So this is what we are going to discuss. So among this score also, ESMO MCBA score, magnitude of clinical benefit scale also, Mona Lisa 7 and Mona Lisa 3, when we combined Prixana with endocrine therapy in Mona Lisa 3 with fulvestrant, first line premenopausal, perimenopausal, first or second line postmenopausal. So quality of life also improved. ESMO MCBA score of 5 and 4. So only therapies achieving a grade 4 or 5 are considered to indicate a proven clinical benefit. So Prixana remains the only CDK4/6 inhibitor to achieve ESMO MCBA score of 4 in first line postmenopausal patient with hormone receptor positive HER2 negative metastatic breast cancer. So difference is superior survival. The only CDK4/6 inhibitor that we have discussed that it has shown overall survival benefit across 2 phase 3 trials. These are the results. Mona Lisa 3 and Mona Lisa 7. Prixana, when it was combined with fulvestrant in Mona Lisa 3 and when it was combined with NSAI in Mona Lisa 7, whether it was given in first line or second line, whether it was disease given in bone only metastasis, visceral metastasis, number of sites of metastasis, these were the patient population. Next slide. So these are the longest overall survival, which was reported with any CDK4/6 inhibitors, that is 58.7 months, approximately 5-year survival. It was seen with ribociclib. And Prixana significantly improved OS in combination with fulvestrant in postmenopausal patients that we have seen that it is median overall survival has not reached the other arm, fulvestrant plus placebo. The overall survival was median OS was approximately 40 months. With Prixana, statistically significant improvement in OS was achieved at interim analysis with a 28% reduction in risk of death. So you can see early separation of the curve from the placebo arm also. So Prixana consistently improved OS in different patient populations with multiple combination partners in postmenopausal, in pre or perimenopausal, in combination with fulvestrant, or in combination with NSAI. So Prixana in combination with any endocrine therapy, it is consistently improving the overall survival. Next slide. So an overall survival benefit was observed with Prixana across all exploratory subgroups. This is first line, early relapse plus second line, lung or liver involvement, bone lesion, whether it was present or not, number of metastatic sites, whether they were less than 3 or more than 3, disease setting, whether it was new adjuvant or metastatic, age group, ECOG PS, almost every patient population, Prixana has shown better response as compared to placebo. An overall survival benefit was observed across all the exploratory subgroups. So this is when we combined it with tamoxifen, NSAI. So NSAI combination was more, patients were more, 73% patients were. ECOG PS0, age subgroup less than 40, prior chemotherapy was given or not, any adjuvant or. So these are the results: consistently delayed time to disease progression across lines of therapy and multiple combination partners. We have already seen median PFS of 20.6 months in Crixana plus fulvestrant, and placebo plus fulvestrant, it was 12.8 months only, with hazard ratio of 0.59. And when Crixana was used in first line, Crixana plus fulvestrant, median PFS was 33.6 months. On the other hand, placebo plus fulvestrant, it was 19.2 months only. And in Mona Lisa 7, when Crixana was given in combination with NSAI, the median PFS was 23.8 months versus 13 months when NSAI or tamoxifen was given along with placebo. And this was in the Mona Lisa trial. Next slide. The difference is quality survival. We have already discussed, and ESMO MCBS score, it is more in Crixana. Next slide. So ABC4 guidelines highlight the quality of highlight the importance of quality of life. You all know quality of life is a subjective concept that encompasses physical, emotional, social, and functional well-being, which is becoming increasingly important in both treatment and access decisions. Interrogative oncology aims to optimize health, quality of life, and clinical outcomes across cancer care continuum to empower people to prevent cancer and to become active participants before, during, and beyond cancer treatment. So health professionals should be ready to change and adapt treatment strategies to disease status, treatment adverse effects, and quality of life. Despite this importance of quality of life, many patients with MBC still fail to receive adequate palliation for the symptoms, which could improve quality of life. So next point with Crixana is that we delay the time to subsequent chemotherapy when we treat with Crixana. So when we were treating with Crixana, early separation of curves was seen in time to chemotherapy was delayed by 50.9 months in comparison to other endocrine therapies, where it was approximately 36.8 months. And chemotherapy-free survival was also more in ribo arm, 42.4 months as compared to 26.4 months in comparison with endocrine therapy. This is how it has been shown that Crixana plus fulvestrant median time to chemotherapy, it has still not reached, but in fulvestrant with plus placebo arm, median time to chemotherapy was 29.5 months. So we have already seen that Crixana improved or maintained quality of life, whether it was pain, whether it was overall fatigue, diarrhea, nausea, vomiting, they all were improved or at least maintained. There was no impairment of work productivity. So talking about Mona Lisa 2. So in first line also, treatment of hormone receptor positive locally advanced or metastatic breast cancer, Crixana extended median PFS of 25.3 months through powerful first line efficacy. So this in combination with letrose, Crixana demonstrated a median PFS of 25.3 months. What is important is here is that there is early separation of PFS curves. PFS curves was seen as early as 8 weeks. So this is median duration of response as early as 8 weeks. We have seen the Crixana plus letrose combination has worked. While in and median PFS was 25.3 months. And median PFS was, with the placebo plus letrose was approximately 16 months. So again, efficacy was seen across all pre-specified subgroups, regardless of patient and disease characteristics, age, ECOG PS, whether it was used in first line or second line, whether it was used in bony metastasis or without bony metastasis, visceral or non-visceral metastasis, number of oligometastatic disease or non-oligometastatic disease, prior neoadjuvant chemotherapy has been given or not. It was effective in all the pre-specified subgroups. In first line treatment of hormone receptor positive, locally advanced or metastatic breast cancer, Crixana demonstrated rapid clinical improvement. So Crixana demonstrated consistent, rapid, and sustained efficacy across phase 3 trials, regardless of combination partner or menopausal status. Whether it was pre-menopausal in Mona Lisa 7, it was used in combination with NSAI plus LHRH agonist. In contrast to placebo plus NSAI plus LHRH agonist, in first line, the median PFS was 27.5 months as compared to 13.8 months in Mona Lisa 7. And when in Mona Lisa 3, postmenopausal patients, Crixana plus fulvestrant, last slide please. Crixana plus fulvestrant or placebo plus fulvestrant, the median PFS was 20.5 months in contrast of 12.8 months. In Mona Lisa 2, postmenopausal patient, Crixana plus letrose versus placebo plus letrose. In first line only, the median PFS was 25.3 months versus 16 months. So rapid separation of PFS curves, as we have already discussed. Next slide. So time to response, we saw that there was early separation of curves as early as 2 months or 8 weeks. We can see the response of Crixana plus letrose. Next slide. At 8 weeks, 3 out of 4 patients with Crixana plus letrose had a reduction in tumor size. So these are the 76% of patients receiving Crixana and letrose versus placebo plus letrose, they had tumor reduction. So rapid reduction in tumor size. This is next slide. So this is pictorial depiction of the thing we are talking, that there is rapid response rate. So this is tumor at baseline and this is tumor size at 8 weeks. So it was a median reduction was approximately 29%. Next slide. So this we have discussed that a clinically meaningful mean reduction in pain was observed in patients receiving Crixana. That is, symptom relief was very early, as early as 8 weeks. According to National Cancer Institute, pain has been shown to negatively affect patients' function and quality of life. So rapid reduction of pain. Next slide. So we have talked about overall survival. We have talked about the rapid response rate. Now, but there are more differences with Crixana. So next difference is the highest level of CDK4 inhibition we can see with Crixana. Next slide. So this is CDK4 pathway, which we are targeting when we are using CDK4/6 inhibitors. So CDK4 and 6 act as key regulators of cell cycle progression, as we all know. So they bind to cyclin D to form the complexes with cyclin D, CDK4/6, resulting in phosphorylation of gene. So CDK4 is a pivotal driver of breast cancer progression. So CDK4 and cyclin D1 complexes play an important role in luminal epithelial proliferation in breast cancers. Ability of cyclin D1 to activate CDK4 was shown to be key to the role of cyclin D1 in breast cancer progression. So CDK4 has been shown to be required for tumor formation in preclinical breast cancer models. So this is the model of CDK4/6 inhibitor therapy. Next slide. So breast cancers are dependent, breast cancer cells are dependent on CDK4 expression and express higher levels of CDK4 as compared to CDK6. This is the how they have shown that CDK4 mRNA is expressed at significantly higher levels than CDK6 in estrogen receptor positive breast cancer specimens. Next slide. So Crixana has shown preferential activity against CDK4. So cell lines in which CDK4 knockdown had a pronounced effect on growth were enriched for those derived from breast cancer. On the other hand, CDK6 dependence was almost exclusively seen in hematopoietic or lymphoid region. When we talk about all the 3 CDK4/6 inhibitors, Crixana has shown almost 8 times the effect of palbociclib in inhibition of CDK4, and it is more than Abema also. So it has the greatest activity of CDK4 inhibition as compared to other CDK4/6 inhibitors. Next slide. And Crixana has more drug available also to penetrate and act on tumor cells. It is more than 520 nanomole as compared to Abema and Palbo. The highest is of Crixana. Next slide. With all the 3 available CDK4/6 inhibitors, Crixana has shown more effectivity for CDK4, and free drug concentration is also more for Crixana. So this is more selectively inhibiting CDK4 and hence more effective. Next slide. So Crixana is the only CDK4/6 inhibitor with twice proven to help women with the hormone receptor positive, HER2 negative metastatic breast cancer live longer. That is improved overall survival in two phase 3 studies, that is Mona Lisa 3 and Mona Lisa 7, with the P ratio, P value very significant. Treatment with Crixana consistently delayed time to chemotherapy and improved quality of life, that we have seen, and more effective CDK inhibition targeting a key driver of breast cancer. These are the three main effects of Crixana. Next slide. So how we optimize patients on Crixana treatment. Early monitoring recommendations because of the to monitor the side effects in cycle 1, baseline and mid cycle. But from cycle 3 onwards, we can have evaluations at the beginning of the cycle only. And for QT prolongation, which is an important side effect of Crixana, after cycle 2, we don't need much monitoring for QT prolongations also. Next. So Crixana offers convenient dosing also. So it is 600 milligram daily, and one tablet is of 200 milligrams. So 3 tablets to be taken at the same time. And if we have to go for dose reductions, it is very easy since the drug availability is in 200 milligram dose. So we can simply quit one 200 milligram tablet and go with 2 tablets, and further dose reduction with one only. Dose reductions more than 200 milligram, the drug is not recommended. So women on Crixana who require dose reductions due to AEs continue to receive clinical benefits. So this is what we have talked about CDK4/6 inhibitors in hormone receptor positive metastatic breast cancers. But when our patients fail on CDK4/6 inhibitors, what after CDK4/6 inhibitors? Next in line is PIK3 mutation. PIK3 is the most commonly mutated gene in HER2 receptor, hormone receptor positive HER2 negative advanced breast cancer. Approximately 40% of patients with hormone receptor positive HER2 negative advanced breast cancer have PIK3 mutation. And importance of this PIK3 mutation is that these patients, they don't do well. They carry a worse prognosis as compared to other hormone receptor positive breast cancer patients. So this is the analysis of 649 metastatic breast cancer patients in which they analyze ER positive disease who have relapsed or progressed during endocrine therapy or less than a year after the end of endocrine therapy. And there was a meta-analysis of 1929 cases, prior adjuvant chemotherapy, endocrine therapy, combination of these treatments. They show that presence of PIK3 mutation was a negative prognostic factor associated with poor response to therapy and overall worse overall prognosis in breast cancer. So PIK3 mutation can be a biomarker of response to treatment and a predictor of prognosis in breast cancer. So when will you check for PIK3 mutation? Knowing your patient's PIK3 mutation status may help in developing upfront treatment strategies. PIK3 mutations have been associated with ET resistance and disease progression and poor prognosis in breast cancer. Because they help PIK3 mutations, they help in cell proliferation, tumorigenesis, they carry poor prognosis and endocrine therapy resistance. So knowing PIK3 mutation status upfront will help in prognosticating the patient and expecting the response to treatment. So Victo, that is alpelisib, it specifically addresses PIK3 mutation. It is a potent and selective inhibitor of PIK3. PIK3 mutation, it leads to hyperactivation of PIK3 alpha, key upstream component of PIK3 pathway. Victo, that is alpelisib, it inhibits the alpha isoform of PIK3 50 times more potently than other PIK3 isoforms, that is beta, gamma, and delta. So Victo and fulvestrant, they work synergistically to inhibit the PIK3 and ER pathways respectively. So targeted PIK3 mutations may overcome resistance to endocrine-based therapies used in hormone receptor positive, HER2 negative advanced breast cancers. So this is a SOLAR-1 phase 3 trial, which led to approval of PIK3 anti-PIK3 drug in this subset of patients. It was a randomized double-blind trial, placebo-controlled, multi-center phase 3 trial, in which there were 572 patients were enrolled, including 341 patients with a PIK3 mutation. So inclusion criteria were postmenopausal women more than 18 years, hormone receptor positive, HER2 negative, recurrence or progression of breast cancer during or after AI therapy, ECOG PS of 0 or 1, PIK3 mutation was identified. They were randomized 1:1 receiving Pluvicto versus receiving Pluvicto plus fulvestrant versus placebo plus fulvestrant. Pluvicto 300 milligram daily. So these are the results of SOLAR-1. Median PFS of Pluvicto plus fulvestrant combination was 11 months, which is double, almost double as compared to fulvestrant alone, median PFS of 5.7 months. And there was a gain which was seen with Prixana also. There is rapid separation of the curves in Pluvicto plus fulvestrant arm also. Again, Pluvicto was seen in all the subgroup of patients, whether it was lung or liver metastasis, whether it was bone only metastasis. Patient has received previous CDK4/6 inhibitor, patient has received previous chemotherapy or not, and line of advanced anti-cancer treatment, whether it was in first line or second line, endocrine status, primary resistant, secondary resistant, or patient is sensitive. So consistently, Pluvicto has shown results in across all the subgroup of patients. So overall response rate of Pluvicto plus fulvestrant combination was 35.7% versus 16.2 with a significant p-value of 0.00202, and overall response rate in this is when patients have measurable disease, and in all the patients it is 26.6 versus 12.2 months. So better response rates of more than almost 2 times with Pluvicto plus fulvestrant combination. Again, the tumor size reduction in Pluvicto plus fulvestrant, we have deeper responses with Pluvicto plus fulvestrant combination as compared to its counterpart. So 3 out of 4 patients with the disease, with the mutation, with the measurable disease, they showed the response. Now the dosing of Pluvicto, it is available in 150 milligram. So dose is 300 milligram to 2 tablets once daily with food. It should be swallowed and taken with food at approximately the same time each day. A recommended dose of fulvestrant is same, that is 500 milligram. It is administered day 1, day 15, and day 29 intramuscularly, and continue until disease progression or until unacceptable toxicity occurs. What are the adverse effects of Pluvicto plus fulvestrant combination? Most common adverse effects, what we have seen is hyperglycemia, or it is the skin rash. These are the effects which have side effects which have to be addressed actually. Why there is hyperglycemia in patients who are receiving Pluvicto? Because glucose the insulin signaling through PIK3 drives glucose uptake into the cell. When we inhibit PIK3, so there is hyperglycemia. So this is how we manage hyperglycemia. If the fasting plasma glucose is more than upper limit of normal to 160, there is no dose adjustment required. And if it is more than 160 to 250, no dose adjustment of alpelisib is required. But yes, we should start oral antidiabetic treatment, which has to be started beyond metformin along with insulin sensitizer, that is glitazone, pioglitazone. When it is more than 250 to 500, then we need to omit alpelisib. If fasting plasma glucose is resolved to less than grade 1 within 3 to 5 days, while off alpelisib and on metformin, restart alpelisib and reduce by 1 dose level, that is 250 milligram dose. And if FPG does not resolve, then we need to permanently discontinue patient from alpelisib. And if FPG are more than 500, omit alpelisib, and in 24 hours, if grade improves, then follow specific guidelines. If it is still at grade 4, we need to permanently discontinue patient from alpelisib, and we need to consult endocrinologist. So in first level is initiate metformin, then increase the dose. If it is still not controlled, add insulin sensitizer and increase dosage to 1000 milligram twice daily if needed. And along with all these medications, we also need to change lifestyle, which is equally important in managing diabetes as in other patients also. So the only laboratory monitoring needed for patients on Pluvicto is for plasma glucose levels, which is also there in initial few cycles of the treatment only. So in first few 2 weeks, we need more than 1 per week of monitoring. And after first 2 weeks, at least one every 4 weeks and as clinically indicated. HbA1c every 3 months as clinically indicated in patients who are on treatment and who are not facing any hyperglycemia. In patients who are experiencing hyperglycemia, so more than one per week is needed, and after first 8 weeks, every 2 weeks and as clinically indicated. This is how frequent we need the monitoring of plasma glucose. Next slide. Next important side effect what we discussed was rash. So in a SOLAR-1 trial, additional sub-analysis, occurrence of rash in patients taking Victo and plus fulvestrant who received prophylactic treatment compared with those who did not. So 26.7% of patients in this subgroup reported rash compared with 64.1% who did not receive prophylactic treatment. So these are the patients.
Madam, we are running at least 30 minutes late. So
sir, I'm almost done. Another 1 or 2 slides. So patients receiving prophylactic treatment prior to onset of rash, there was 73% patients did not receive, experience any rash, and only 12% of patients received experience only grade 3 or 4 rash. And patient who did not receive any prophylactic treatment, 36% experienced no rash, while 23% patients received grade 3 or 4 rash. So consider using prophylactic measures including antihistamines before initiation of Victo and during Victo. Next slide. So PIK3 mutation testing is a critical component of hormone receptor positive HER2 negative advanced breast cancer. So PIK3 mutations can occur in multiple coding regions, most commonly exon 9. So how to test? PIK3 mutation testing can be done on the tissue. Next slide. And PIK3 mutation testing, we can go for liquid biopsy also. And if patient is if we are going for liquid biopsy first, if patient is negative on liquid biopsy, we need to do PIK3 mutation testing on the tumor tissue before prescribing the therapy. Next slide. So I'll be summarizing. PIK3 mutations are present in 40% of patients with hormone receptor positive HER2 negative advanced breast cancer, and they indicate a poor prognosis. Victo tablets specifically target PIK3CA mutations. They nearly doubled mean PFS in patients with PIK3 mutation, which was approximately 11 months as compared to 5.7 months in the other arm. More than double the response rate with 35.7% versus 16.2%, and with manageable and reversible side effects. So Victo is a biomarker driven therapy with NCCN also recommends this in PIK3 mutation. Next slide. Manageable safety profile we have already discussed. Thank you. Thank you to the organizers and respected chairpersons.
Thank you, Dr. Jyoti. I think we are quite late actually. I think we'll go on to the discussion, the panel discussion, and maybe like a lot of questions will come there. The moderator, Dr. Chandragowda, the panelists, Dr. Bharat Chauhan, Dr. Darshan Rane, Dr. Pankaj Goel, Dr. Sujina Joga, Dr. Manish Sharma, Dr. Venkat Pradeep Bob. Over to Dr. Chandragowda.
Thank you very much, sir. Thank you, Dr. Kumardeep, for giving me this opportunity. So I'm just sharing slides. I think the slides are visible straight away, right?
Yeah. Yes.
Right. So without wasting time, so my task is to invite speakers straight away and start the sessions. So shall I invite Dr. Darshana Rane? Is she there? Dr. Pankaj Goel, Dr. Sujina, and Dr. Venkat. And I will also request, I'd also request Dr. Varun and Dr. Kumardeep to join the panel, please.
Yes, sir.
Yeah, thank you. So my task is to cover HER2 new breast cancer in 2021, newer challenges. So when I was given this topic, I was thinking, what are the challenges that I face? Probably some of the expert panel they may not be facing it, but I will just put across the challenges that I face in my clinic when I treat the HER2 new breast cancer patients. So some scenarios are in the adjuvant setting, some scenarios in the metastatic setting. So without wastage of time, so I'll move on to the next slide. The challenge number one is Mr. Roshi. is a 50, it doesn't correlate with any company name here. So just putting it across. So Mrs. Roshi is a 50-year-old postmenopausal lady. She is a locally advanced breast cancer, right side, the ER 70, PR 70, HER2 3+. She was treated with the 6 cycles of TCHP and followed by MRM. So first question, Venkat, how comfortable in neoadjuvant setting with this particular scenario you are to avoid anthracyclines? So would you avoid anthracycline, or you add on to an subset of the category in there?
So I am more comfortable with when I am using anthracycline, I am more comfortable with AC followed by THP regimen, so more than TCHP. So if I want to use TCHP regimen, definitely like it is one of the good choices, but I am more comfortable with AC followed by THP.
Okay, so comfortable with more of ACTH. Okay, so I don't want to because waste time here, because our task is to cover the HER2 positive disease. So challenge number 1 here is that you have used the TCHP and the patient has undergone MRM. So the histopathologically it was revealing residual DCIS. So now it is how to proceed, Dr. Darshana, how do you proceed in this particular scenario? So now we have locally advanced to start with, post 6 TCHP, residual DCIS. How do you proceed? Dr. Darshana is not there. The Pankaj can take it.
Sir, when we have DCIS, then I think we can really take it as a very good response to TCHP. Okay. Depending upon affordability, I can very well go with just maintenance H plus minus PP would not have a very drastic addition improvement in that.
So that's where the first challenge is. Yeah, that's why I told this is the first challenge for me.
Yeah, and just on the basis of DCIS, I don't think I'll be offering TDM1 to this patient, this particular patient.
Okay, so you are not offering TDM1, agreed. Would you add, as you said, pertuzumab in this scenario, because that's where we need to have, we have to probably plus minus with, because it was a locally advanced disease to start with. Would you add both anti-HER2 or only one?
Sir, in hormone positive disease, we have given pertuzumab in adjuvant setting, and with such a good response, I don't think there's a very big need of continuing pertuzumab. I'm happy continuing without pertuzumab.
Dr. Sujana, any difference of thoughts in this scenario?
No, sir. Since it is not a residual invasive disease, I would go with maintenance trastuzumab. And pertuzumab depending upon the affordability, but we do not push for it.
Okay. Venkat?
Same, sir. I agree, sir. So it is HER2 3 positive. So trastuzumab is good enough, sir.
Okay. Thank you. So now coming to the second same patient, if she would have had a residual IDC, a YP-T1, YP, and 1. So what would you have done? So Dr. Varun, your thoughts on this?
Yes, sir. So because this is residual invasive disease, now we can offer TDM1 as adjuvant setting.
Okay.
That is there. That will be better.
Okay. So there's no confusion in this regard. So now my question is, so role of extended anti-HER2 therapy in this scenario. So in a first scenario where the patient has achieved good response, almost a path CR, and then in that regard, would you give an extended anti-HER2 therapy? Dr. Darshana is there now? Dr. Darshana? No. So Dr. Pankaj, again, the ball is in the court. So in a role of extended anti-HER2.
So by extended, do you mean the maintenance completing the 17 cycles, or?
After completion of 17, so would you extend by 1 more year niratinib here in this scenario?
So niratinib can be added in this case, though we have not practically used it. But I think in this specific segment where patient is high risk and hormone positive, niratinib still remains an option.
Okay. So Venkat, which scenario do we use? So suppose if a patient has completed a significant residual disease and completed Kadcyla, and despite in that scenario also you add it, or only patients who have received only the trastuzumab maintenance?
So one thing is that a lot of toxicity is reported in niratinib adjuvant setting. So probably after using in the real life setting, I would then consider using neratinib for 1 more year. So, but theoretically, it is definitely one of the options.
Okay.
But I would like to use only after getting a real world data, sir, because in adjuvant setting, particularly, already we are giving 1 year of adjuvant IV therapy. And although this is one more therapy of extended adjuvant, I would think twice, sir.
Okay. Dr. Kumardeep, your expert comments on this?
Expert, sir, Dr. Duval sir is there. He will give expert comment on this, but because he has
Sir will give a final authority.
Final. So, like practically, I think it will be too much if we give PTCH, then followed by TDM1, then again after TDM1, neratinib for 1 year. It is very difficult to find patients who can take TDM1 after 6 cycles of PTCH. So again, the first hurdle is financial hurdle. Second is like I'd rather wait for the recurrence to happen to consider for the neratinib rather than giving neratinib to complete 2 years of anti-HER2 therapy in the adjuvant setting.
Dr. Sujana?
No, sir. Extended anti-HER2 therapy in post-trastuzumab setting only. It is the trial was done, not in post-TDM1 setting. So, and it's a difficult drug to tolerate also. So, I would not go for neratinib, sir.
If at all you have been given a chance, where you would like to use this?
Extended anti-HER2 therapy with neratinib.
Yeah.
In hormone positive patients and HER2 positive, triple positive patients.
So triple positive patients who use it. Okay.
Yes.
So I think the panelists, I mean, here have been divided. Some would like to use it, some would not like to use it. So let's see what data suggests in this particular scenario. So we know that neoadjuvant TCHP has been standard of care because of these two trials, and there are train 2 where an anthracycline can be avoided, so that the efficacy of whether TCHP or avoiding anthracycline would remain the same. So you have an option of taking out anthracycline. So initial thought of adding anthracycline would benefit more, so that is no more there. So when you talk of a high risk HER2 positive ABC, it may be upfront after surgery, or it may be after and neoadjuvant. So any residual disease which our panelists talked about is a high risk disease, would straight away go to Kadcyla, that's TDM1. So this is how the maintenance setting has been. So neratinib, the extended benefit, which was published in 2017. So that was one, and then the trastuzumab pertuzumab was the second one, and the TDM1 was the third one as per the Catherine. So affinity has shown in adjuvant setting that yes, patients who have been undergone surgery, a high risk HER2 positive, adding both anti-HER2 blockade has resulted in some benefit in terms of IDFS. Mind is only IDFS, however, there isn't any benefit in terms of overall survival. So it's more so in patients who are node positive, and negative in node negative doesn't much. So IDFS by hormone receptor, so it's more so that's the benefit is only seen in patients who are the hormone negative, which is more consistent compared to hormone positive. So this is what we are talking about, the extended 5-year update trial of a neratinib post trastuzumab. So that's very important. A patient who has received a post trastuzumab neratinib versus placebo, neratinib was given for more than 1 year or one more extended year. So this 5-year IDFS analysis showed a delta of around 2% favoring neratinib. So this is by hormone receptor status, what was talked about by one of our panelists, expert, Dr. Sujana, saying that the hormone receptor status, the benefit is more, but in hormone negative, it is not that so. So more so in a patients who have had did not achieve a PCR. That's what my question was. A patient who has a significant residual disease and received only a trastuzumab maintenance, their delta is 7.4% compared to who have achieved a PCR. So in a patient who is hormone positive, did not achieve, and this is a significant residual and is not affordable for a TDM1, and have given only trastuzumab, I think that's where I feel we should consider the extended the neratinib. So even the overall survival benefit wasn't seen in an intention to treat population. However, the subgroup has shown that without PCR post neoadjuvant, the good delta of 9.1% was seen with the neratinib. So that's the one. And Catherine, as was talked about, that there is definitely you should have a pathological CR. If CR, you should not. There is some sort of invasive disease. That's where we probably start this particular. And there's an IDFS benefit. So this has been talked about. Now coming to a second challenge. So the patient developed the metastatic disease within 5 months of completion of her maintenance. So she was given hormones, and then now she's got a metastatic in lung, liver, and bone. So Dr. Sujana again, and then followed by Venkat. How do you proceed with this particular scenario?
First, we would like to do a repeat biopsy from the lung or liver lesion, sir, to see whether it's still HER2 positive.
Okay. If it is HER2 negative?
If it is HER2 negative, we would drop out the HER2 options and would think of hormonal therapy.
Okay. Would you agree, Dr. Venkat, with Dr. Sujana's thoughts?
This patient received neoadjuvant therapy with pertuzumab, trastuzumab, chemotherapy, and then she achieved pathological complete response, and then TDM1, and you said
she has not received TDM1. She just H maintenance.
Neratinib also, sir?
No, she has just received a H maintenance. So that's what I told. She's H maintenance. After H maintenance, within 5 months, she failed.
Okay. After trastuzumab, only trastuzumab, sir, no TDM1.
Yeah, no TDM1.
So as per current guidelines, so because she's a complete PCR, she received H maintenance, and within 6 months she relapsed. So one of the options now is TDM1, sir. And definitely I would like to want to do brain MRI also, sir, in this patient, because she's HER2 positive and lung, liver, bone mets are there. I want to look at a brain.
The brain is clear.
Then TDM1 is, as Sujana said, biopsy can be done and to look at the hormone profile and HER2 expression, and we can go for TDM1, sir.
Okay. Dr. Pankaj, your thoughts on this issue?
Sir, I think I concur with the previous speaker. If it's a HER2 positive disease, still a HER2 positive disease, then TDM1 is supposedly the best option. Correct. When the patient is treatment naive for this TDM1, it's not been given the adjuvant.
I think I concur with the adjuvant because we have data from Marine. Would you do a Cleopatra in this scenario also? Pankaj, would you also give an option?
Had the disease-free survival, the disease-free interval, had it been long, then of course, yes. But in this case, it's hardly 5 months. So I don't think PTCH will be a very good option.
If it had been 7 months?
Sir, at least more than a year.
Okay. So, Venkat?
Sir. Yes, sir.
If it was with 7 months, the patient had developed a metastatic disease, maybe 6.1 months. So what is your choice?
So these, just like platinum resistance, I feel that these 6 months, if it is 6 months, 1 day, these are only arbitrary reasons.
Yeah.
So because within 6 months, had she developed only one metastasis, probably, but she has very extensive disease within lung, liver, visual metastasis, bony metastasis, and she is hormone positive also. But so I think TDM, I will go for TDM1, sir, in this patient.
Okay.
It's not just 6 months. It's a line of Lakshman Rekha.
Yeah, I concur with you. So I think Marine has shown that yes, TDM in less than 6 months is what is you can use that in the frontline setting as per the Marine data. So now to wind up,
just one question. As Sujana have told that she will do again ERP and HER2.
Yeah, that's right.
If HER2 by any chance comes negative, then whether we should take it negative or just because of heterogeneity, maybe.
Sir, if we are not taking it negative, then why we are doing the biopsy?
Yes, so I think biopsy should be done just to confirm metastasis, like it is stage 4. And I think within 5 months there is no need to do hormone status again.
There are chances that there may be drop in the HER2 receptor status. 5 to 10% chances are still there.
But would you do it so early? So even if it is negative, would you not use an anti-HER2 treatment here? As one was pointing out.
By that logic, this disease is not behaving the way it should. It has recurred so early after 5-6 months. So in our practice, we usually do repeat the test before going for some costly medicine.
But that's what I mean. The point is whether even if you do it, would you follow that? You won't use an anti-HER2 treatment in this. That's the question here.
We follow the report.
Okay. Sure. So that's the answer there. So I think I don't repeat in less than 2 years. So unless it is mandatory. So I think we have seen discordancy of the ER/PR positive, but even if it is negative, we have seen that we are using the information and probably go ahead with the treatment. So that is the challenge number 2, and the challenge number 3 is 65-year-old lady. She is a de novo metastatic breast cancer. She is a disease everywhere: liver, lung, small asymptomatic supracortical brain mets. There is no visual crisis. She is ER/PR negative, HER2/neu 3+. So how do you proceed, Dr. Varun? How to take this case?
Sir, we can go ahead with the dual inhibition HER2 with trans2.
Okay.
Otherwise,
would you add radiation, or you refer across to a radiation oncologist?
No,
for
patient is asymptomatic, single lesion, small lesion.
The multiple supracortical brain mets.
Still, patient is asymptomatic.
Okay.
We can start with chemo, and if patient becomes symptomatic, we can go ahead with the, because there is systemic disease burden is also high, liver, lung, and all. So we can start with chemo and HER2 blockage, and then later, if patient becomes symptomatic, that time we can go ahead with radiation.
Okay, Dr. Sujana?
Yes, sir. I would also start with the chemotherapy, PTH first, and then if the patient only becomes symptomatic, we will go with the whole brain active.
Okay. So if it were to be, the infracortical lesions, so would have done the same thing, though they are asymptomatic? Dr. Venkat?
I agree with the approach, sir, but at the same time, I want to ask esteemed panel whether we approach the brain mets in hormone positive and HER2 positive separately. Like, is there a role of SBRT if there is a single mets? Do we treat separately if there is single mets in hormone positive versus HER2 positive?
So, Dr. Pankaj, take that. Yeah, Dr. Pankaj.
Sir, I just want to say that in patients with this HER2 positive, we do not actually rely so much on the systemic therapy that we omit radiation. Okay. Maybe if the systemic is high, then we can probably start with the systemic therapy, but then during further course of time, maybe in the midst of first and second cycle or later on, we definitely try to incorporate radiation rather than just being happy that the systemic therapy will take care of the brain mets. Unlike the lung, in which we have very high response rates with these TKIs. In breast, preferably we address the brain, not just wait for the symptoms to appear.
I have Dr. Darshan Rane wants to.
Hello.
Dr. Darshana Rane has joined.
Yeah, Dr. Darshana. I think you have seen this scenario. What's your opinion on this scenario?
So I would agree with the fact that being asymptomatic, we can go ahead with the targeted therapy. I mean, with the systemic therapy, I mean, that should be more sufficient. When because the brain mets are very small and asymptomatic, we can leave them alone. And most of these diseases will definitely have another brain mets. We can reserve that whole brain RT for that future.
Okay. So intent of putting this patient here is that some of these patients are long-term survivors. Using a brain RT upfront may probably lead to a cognitive dysfunctions early. So the reason why I put it, have anybody has an experience of using intrathecal trastuzumab in the maybe a meningeal met? So do you have any experience of using intrathecal, Dr. Venkat? In addition to a systemic treatment?
One patient with leptomeningeal mets, along with the trastuzumab, because she is not affordable for TDM1, we have given intrathecal trastuzumab, sir. And we use the same formulation as IV, sir. Right. Based upon very few literature case reports are there. Based upon that, we have given, sir. She did well for 5 months, sir.
Okay, so there is an option if patient has in addition meningeal mets, so probably we can use an intrathecal. So just
Chandragouda, as we are running late, so
okay, last question. I think I'm coming to an end. Last question is this.
Right.
So just one query. Whether we can use neratinib because that molecule had some brain penetration.
I think I'm coming to that point. And why not tucatinib, trastuzumab, capecitabine in this setting? No, it is a third line. I think this is the one which probably will come into a frontline in patients who have these kind of asymptomatic brain metastasis and have a. So that was my question: whether will you inch probably towards because this is what I faced recently, and oncologists in the US, why not tucatinib, trastuzumab, capecitabine? I told you, there is no data in this regard. So how do you take it, Venkat?
Yes, sir. Definitely, it will pave its way into first line with brain mets, sir. Because of the excellent intracranial responses, it will. Correct. Yes, sir.
So, with that, back to you, Dr. Kumardeep, and I thank all the extreme, expert panelists for their opinion on.
Chandragouda, sir, last one, please clarify that point. Whether you consider SBRT for any single mets in brain mets, will you consider based upon HER2 positive versus hormone positive, sir? If there is a single brain mets.
Definitely, I'll agree. So suppose if there's if I'm using if it's a small brain metastasis which is single, I'll do an SBRT and then proceed to the system treatment. Right, in either scenario, yeah.
Okay, sir. Thank you.
Thank you all. Thank you, Dr. Thank you, Dr. Chandragouda. Thank you, Dr. Ramesh Nwagadda, sir, Dr. DC Doval, sir, Dr. Rajesh, for chairing the session. For next session, I would call Dr. C. Sairam, sir. He is Director and Senior Consultant Medical Oncology at Swarna Sai Hospital, Hyderabad, and Dr. Roshan Prajapati. He is a Senior Consultant Medical Oncologist at Bhagatpur Cancer Hospital, Nepal. Dr. Sairam, sir.
Yeah, thank you for giving me the chance to chair this session. I would ask my co-chair to introduce the speakers and start the program. Because we are running late, I think we should go straight away with the program.
So it's debate of nephrectomy versus no nephrectomy in RCC, metastatic RCC. Speaker for the debate is Dr. Bharat.
Dr. Bharat is there?
Yeah.
Yeah.
Should I start?
Yeah. He's from Yashoda and he's going to speak. Is there role of cytoreductive nephrectomy in metastatic renal cell carcinoma? In probably he'll be speaking in symptomatic, asymptomatic, and I mean both the cases. I think so. He will be. We are happy to hear from this.
Thank you, Kumardeep, for the kind invite. Am I audible?
Yeah.
Yes, you're audible. Audible. Yeah.
Yeah.
Slides
so
are also
thank you.
visible.
Thank you all. Now, this was my first reaction when I was given this topic. Kya karne aaya tha main. Then I started reading because I was probably slightly against, or I can say I had a neutral view. But in the next 10 minutes, I'll convince you that or what we say cytoreductive nephrectomy is a way to go, but definitely not in everyone, but in a select group of patients, and I have a data to support it. So the most important thing is, do you require a cytoreductive nephrectomy in every patient? And whenever you require, when and why? So let me make you understand that this 10 minutes is dedicated and on a scientific discussion, and I'll not like to put my finger on a poor risk patient. So be sure there is no role of cytoreductive nephrectomy in poor risk patient unless there is a very good response to targeted agents or immunotherapy, which happens in 8 to 10% of the patient, or sometimes for a severe pain when there is a due to local disease or a hematuria. I am debating whether cytoreductive nephrectomy has a role in good risk, intermediate risk patient, and I'll tell you the data which supports it. Now my colleague or my dear friend, Professor Anita Madam, will definitely debate me and try to tell only regarding these two studies, Carpina study and Certine study. But I'll tell you my greatest support is with these studies only, and I'll prove it how. So there is a lot of shortcomings in these studies. So let me debate my data on pre-Carmina, Carmina, and post-Carmina. Now, when you look into the initial data of cytoreductive nephrectomy, please understand this was the initial paper in 1997. Please understand, even in these patients, they never did a cytoreductive nephrectomy when there was a CNS, liver, bone mets, a poor performance status, a non-clear histology, or when the extra renal load was too bulky and you were not able to remove at least 75. These were older. Subsequently, lot of other variables came like albumin, LDH, but please need to remember what I have underlined it because that is a way that Carmina has been compared. The first positive data came in the UCLA analysis where cytoreductive nephrectomy was compared with or without immunotherapy, which was high dose interleukins. And here you find there was an improvement in overall survival. These were the two pivotal studies in 2001. One was a SWOG study and one was the EORTC study by Flanagan and Mischis. In both these studies, they suggested, yes, there was twice the improvement when interferon alpha was combined with nephrectomy as against interferon alpha as a single agent. Then came the data of SEER. This was probably the biggest data. The good thing about the data was for the first time now they had decided to categorize where you should do a cytoreductive nephrectomy, but at the end, up to 3 risk factor, if you say that there was a statistically significant improvement in OS versus no cytoreductive nephrectomy. Then came a data of Choudhury et al. This was probably one of the bigger data. Again, suggested that yes, in the era of targeted therapy, when we call as VEGF-TKI, that is sunitinib, sorafenib, there was an improvement and it was twice with the reduction in the risk of death by 56%. And this improvement was more obvious in those with a good performing status. The biggest data again hangs in a retrospective analysis. We follow this IMDC, which is a Hanks criteria. Again, he suggested that yes, those patients with less than 3 risk factors, there was a statistical significant improvement, 20.6 versus 9.6 with a 40% reduction in the risk of death. So yes, there was an improvement in cytoreductive nephrectomy. This was the biggest data till now, which was published in 2019, which included targeted therapy and era by Bhinde et al. Now, this suggested that yes, if you see just 0.5, so the biggest data with 40,000 patients again suggested that yes, in a properly selected patient, the best data is when you do a cytoreductive nephrectomy and there is a 50% improvement or reduction in the risk of death. Now, what we use it, we either use a MSKC or a IMDC, a minor distance only. LDH, which is not included in IMDC, and a platelet and the ANC is not included in the MSKCC. But if you see 0, 1 or 2, 3, 4, more or less, it suggests the same thing that lesser risk factor, better 1 to 2 is a questionable thing which we tell. And then the situation changed, and that is the debate all about. There came 2 prospective studies, Carmina and Certine, and that probably created a confusion. And I'll be discussing these 2 studies. That is the main thing. Look, Certine was surgery at what time? It's supposed to be a Certine, which compared nephrectomy followed by sunitinib versus sunitinib for 3 cycles, then a nephrectomy, and at 28 weeks, the progression-free survival. But we were more interested in overall survival. So it never answered the question that whether you should do a nephrectomy or not. It answered the question, what should be the time of nephrectomy rather than whether you should do it or not. And if you see the thing, delayed nephrectomy is better than upfront. This was the most important thing that came out. So again, I'm not telling that you should do it upfront. Yes, in a subset of patients with a risk floor of 2, you should do it as a delayed nephrectomy. And that was what suggested in 2 big papers that came subsequently by Brun et al. And Bhinde et al. That yes, in a patient who responds well, or whenever you think of doing it in the era of poor risk, you do it in a delayed factor. So delayed cytoreductive nephrectomy better than upfront as per these 3 people. But then again, the most important debate is Carmina or no Carmina. And that is what we call it the elephant in the room, whether you ignore me or you should not ignore me. Now, please see the Carmina study. 450 patients, 226 were assigned to cytoreductive nephrectomy zone, but 40 did not take sunitinib at all. So in the 186 patients who were taken for safety, 16 did not undergo surgery. So you are talking about 226 patients, and at the end of the day, only 170 patients followed your protocol. See the other arm. 224 patients were elected to sunitinib arm. 213 were included in safety. So most of the patients took sunitinib. But the most gross thing was 20% of the patient in sunitinib arm in fact undergone cytoreductive nephrectomy. So here you are talking about 40% patient in the first arm did not take sunitinib. In the other arm, 20% in fact undergone the surgery, which was not mandated here as per as the trial. Of course, Anita madam will debate that yes, sunitinib is better because it is it. But let me tell you the other glaring errors in the Carmina, and then again I'll tell you why Carmina told that you should in fact do a nephrectomy. See the subset of the population who were bagged. T3, T4, 70%, N1, N2, N3 close to 50%. But for me, bone, lymph node, around 70 to 90% of the patient in fact had metastasis. See my previous 1997 paper. Node, bone, these are always bad. I never debate that we should do a cytoreductive nephrectomy in poor risk. My thing is good risk, intermediate risk, you should always think of doing your cytoreductive nephrectomy. 8 years were taken to enroll 450 patients, and that is one patient, less than one patient per year. Suggests that potentially eligible, what we say, are never enrolled. Carmina had more metastatic sites, more burden of lymph node, lung, and bone, possibly exclusion of potentially better. In fact, they only took poor risk patients. 17% of patients in sunitinib arm only undergone cytoreductive nephrectomy. Exclusion was left to investigators. There was no selection criteria. It was entirely left to investigator how they selected it. Possibly they left the patient which were fit enough, although metastatic. Selection of these patients was not in accordance with what we see real world. We never do it in a poor risk patient, and hence you cannot generalize it to the intermediate risk because all those patients who were bad were taken in the study. But if you see the update, this is for me the most important. It is what we call as Vakar UNESCO Yorker. Is there a role of cytoreductive nephrectomy in the intermediate risk? That is what I wanted to debate. So if you stick into the analysis, in fact, those patients with a one risk factor, cytoreductive nephrectomy plus sunitinib was better than sunitinib. And that is the crux of presentation. Intermediate risk, one risk factor, please go ahead and do your cytoreductive nephrectomy. When you look into two risk factor, it was the other way around. I will like you to look into this analysis that was published in ESCO 2029. Look for your certain studies and you look for risk factor in where there were two risk factors. So these were more or less the same. So what they suggested is these 38 patients who undergone a cytoreductive nephrectomy more oftenly had two risk factors. So what you are seeing is probably in two risk factors, most of them undergone a secondary cytoreductive nephrectomy. So you can always debate it when you have a two risk factor, whether you should undergo or not. And that was suggested in ESCO analysis. So should you do a cytoreductive nephrectomy? Yes. In intermediate risk, again, depending upon how the patient profile is. This was the recent paper which was published in ESCO GU 2020. And I will always be debated that what about immune checkpoint inhibitor? And that is 4,000 patient data, which when they analyze that if you see, in a properly selected patient, there was a statistically significant improvement in the risk of death. So 52%, and even in immunotherapy checkpoint, it was 56%. What did this paper tell you is the most important thing. You should think of your cytoreductive nephrectomy in patients who are younger, no adverse factor, IMDC 0-1, no adverse histology. I have never debated in poor, I am debating in good and intermediate. And what they suggested is upfront cytoreductive nephrectomy should be considered in favorable intermediate risk who are candidate for active surveillance. This is what the crux is. 3-4 lung lesion with a big kidney mass. I'll remove my kidney mass and observe it whether these lung lesions are increasing or not. Because as per as the Rini et al. Study, you could still observe them for 22 months. I will do a cytoreductive nephrectomy in oligometastatic disease and in a highly symptomatic primary disease where minimal extra node. I can think of my deferred cytoreductive nephrectomy in that 10-20% patient who did very well in metastatic site, and the primary site is only disease, because I can stop treatment if there is no active disease. What about European guideline? My colleague will debate on this. Do not perform cytoreductive nephrectomy in poor risk. But you should do a cytoreductive nephrectomy in good risk patient. That is what they have said. And when you talk about intermediate risk, the strength is weak, and they have suggested that in the patient who respond well, you can still go ahead and do a cytoreductive nephrectomy. My last data, Canadian, this is one of the best things. Please look into it, a practical. A patient with a good performance status, minimal symptom, resectable tumor, limited burden of disease should be offered a upfront cytoreductive nephrectomy. Conversely, a significant symptom, central nervous system disease, a limited burden within the kidney with large extra volume disease, rapidly progressing, poor performance status should not undergo cytoreductive. And in between the two, start yourself with either an immuno-oncology drug or a TKI or a combination. And if they respond well, think of your cytoreductive nephrectomy. So if I have to summarize, surgery will always remain a multidisciplinary approach in metastatic RCC. I think everybody does a cytoreductive. Please understand, the catch is you should select the proper patient. So patient selection remains a critical component for overall success with cytoreductive nephrectomy. 3 indications. Why? For symptomatic relief, I can observe my patient if the extrarenal burden is low, and definitely in a properly selected patient, overall survival benefit is there. In whom I should do it? In a good intermediate risk patient, yes. 1 is definite yes, 2 you should debate, not in poor. And when I should do it? So it should be upfront. In good risk, delayed, yes. Maybe in IMDC 2 you can delay it. You have a certain data and you have a data of Carmina. In fact, Carmina is the biggest advocate that in a properly selected patient it improves survival. So Anita madam, can I rejoice now? Because I have tried to put my points of where you should do it, and you can never drive away from this point that in a properly selected patient, this is the way to go, definitely not in poor risk. And I end my talk by thanking you and telling you a basic message. Act as if what you do makes a difference. And I think so, doing a cytoreductive nephrectomy, so a right person, right time, a right decision will definitely help in improving the survival of the patient. And I thank you all for a patient here.
I thank Bharatwaj for making your argument as strong as possible. Now I request Anita to counter the argument, because at MNJ Institute of Oncology and Regional Cancer Center, I find it very difficult. I'm not taking any sides, but I find it very difficult to convince the surgical oncologist to do surgery, because our patients' quality of life to begin with and perioperative mortalities, we know how high are there in at least in government setup or regional cancer center, poorly nourished patients. Okay, I'm not supporting anybody. I think Anita will take care of all these points for her opposing our speaking against the nephrectomy.
Sir, I have spoken the data only. You can always.
Yeah, because data is mostly based on the Western population, where we feel it very difficult to practice in most of, at least government setup patients. I had to really beg my surgical oncologist to do nephrectomy. Okay, we'll see how what Anita has to say.
Yes, thank you, Dr. Sairam. And then that you brought in the main key point. And though you said you are not taking sides, but somehow you took. So let's move on to see the targeted therapy with or without nephrectomy. Warm greetings from our university hospital, where we do treat 80 to 90% of the population. That's what India represents. And that's what you said, our chairperson. It's the difficult population to treat. So don't forget about the prognostic factors, and you have the IMDC as well as the MSKCC. Slight difference, but that gives you clinching point and an area where you differentiate whom to do and whom not to do. And as my colleague and co-speaker knows that, yes, we are a medical oncologist and we have come advanced and we have drugs after drugs and big armamentarium, leaving logistics aside. And if you have a theoretical option, we have so many of them, and why don't we use it? And why the surgery, once again, where people are trying to come down with the surgery as much as possible. It's just to remind we have so much to do with these drugs. Now, coming to the next slide. Okay. Yes, also another important thing, like what Dr. Sairam brought into the picture. Yes, we need to discuss is that we do not, yes, again, any decision taken in these type of advanced cancer needs to be discussed. What's the efficacy? What's the evidence I have? Can I use it on you? Is it affordable? Is it easily can be done? How can I convince my surgical oncologist? And how can I convince my patients? So all the things, and how do you apply for the post-operative things? So that brings us into the discussion. Back in 2005, we had standards of care within when nephrectomy was a standard of care. We are changing, we are advancing, and you have seen that beautiful curve telling us we have so many drugs with us. And with the new evidence, yes, cytoreductive surgery does play a role. My colleague has nicely said, though there is so much of mortality, morbidity with the process, which was not discussed at all. Yes, targeted drugs do have, but being a medical oncologist, we have learned over a period of time how to manage this. It's just awareness, patients education, and we can come through. Cytoreductive nephrectomy is an integral part. Yes, what she has correctly said, a good performance status, and it was demonstrated in many of the trials in the prospective data. But still date, we are trying to move away from the big surgery in the end of life when we are considering a couple of months, okay, in a very metastatic disease. So why do you want to do an upfront cytoreductive nephrectomy to these people? But yes, if you have a low metastatic burden, good performance status, yes, go ahead and call your surgical oncologist, but not in the poor performance status and advanced stage. And that's what the most of the population, if you see the data and you compare the metastatic disease, hardly we do get people with low metastasis and good performance. All they come, at least in my medical college, and like how Dr. Sairam said, in a regional cancer center, that's what the bulk of the population. It's an advanced stage scenario where systemic therapy can be the only option. Yes, we do discuss about surgery with them because they need to know. We do take an opinion of surgical oncologist, but definitely patient relation as well as seeing the things. Yes, so there is a systemic role and patients too many times prefer it. Now let's see, this is the data with the NEGM 2018 where sunitinib was used, Carmina trial looking into the intermediate risk population where cytoreductive nephrectomy, it was a phase 3 trial, got us good data, recently publishing, and it showed non-inferiority of the nephrectomy sparing arm. And it spared us from the morbidity and mortality. It took 8 years to complete. It was a slow recruiting study. So you understand the many of the other logistics which were involved. Did have high risks of poor risk patients who were involved in this, and you can see the percentage, okay, 44 to 41%. And the patients in the nephrectomy sunitinib arm had higher rate of advanced disease than those who were just in the sunitinib arm. So that was 70% versus 51%. And coming to the next thing, if you see, that's how the risk factor analysis in this Carmina trial of the intermediate risks. And leaving aside all these other parameters, let's see into the overall survival intent to treat population with single factors versus the 2 risk factors, and those with the sunitinib alone arm. So that gives you a little better, it's an updated in the ASCO 2019, where cytoreductive nephrectomy. So you have to remember it's a heterogeneous population. Treatment strategies do differ when you have 1 risk factors versus 2 risk factors, and most of our patient presents with more advanced disease, more poorer risk factors. So cytoreductive nephrectomy is benefited to a solely smaller portion with 1 intermediate risk factor, especially maybe a single oligometastatic disease, whereas the volume increases poor performance status, and they are not the ideal candidates for the surgery to be done. Previously, we did not have data, we could not tell, but now we have. And if you see, the median overall survival was 18 months, almost around 5 to 6 months compared to the 13.9 months. And so that was something very positive, and that led to the world, yes, why not think differently? Why do we have to go and subject them to surgery? So this prospective Carmina trial showed that targeted therapy alone is non-inferior in OS compared to the targeted therapy and giving you OS survival. My colleague also mentioned about certain trial. It did show a delayed nephrectomy. That means you don't do them, let them improve, let the disease be under control, then take them for nephrectomy. There was a similar PFR and a possible OS advantage compared to the intermediate cytoreductive surgery. That also gives you a thing, yes, start off, let the disease burden come down, and then we can subject to them for a surgery. So yes, it's a whole gamut of disease. Yes, cytoreductive surgery is still a standard of care for a small section of good performance status and very low risk disease. Yes, where you can convince them, but remaining may not be a candidate for this nephrectomy. These trials did have poor accrual. I told you 8 years it took, and it was shifting because it was a very landmark study when people started thinking differently and shifting landmark of the upfront treatment. And but one thing was that yes, we did not look into the modern drugs because as the trial changes, and neither my co-speaker talk about the newer drugs and how much the response rate is even higher and even faster. And then where do you keep cytoreductive surgery when you are going to give the gamut of the newer drugs? So, and also my colleague did not talk about clear cell histology, papillary histology, sarcomatoid histology. Okay, fine, they may be a smaller portion, but yes, when a debate needs to be mentioned that they were not considered for discussion. So yes, retrospective trials was selection biased, but when you adjust the prognostic factor and there's a reasonable portion of the patient to offer not to give the cytoreductive surgery, particularly in high risk. But yes, if you see the red, low metastatic volume, good performance status, favorable histology, that's where you should be them. And be a little flexible with the cytoreductive nephrectomy and without a careful multidisciplinary board evaluation. And I think we forgot to mention earlier that yes, a surgeon has to be involved when we are discussing these type of disease, even the pathologist to tell us what is the biology of the disease, and the surgeon needs to be brought into the picture before we medical oncologists say that upfront cytoreductive nephrectomy. So that's for the students. And the response is quite good in these things, and a good palliation is being observed. So coming to a couple of few slides at the end. So with this, I know this subset of patient with a good performance status, high tumor burden, the Carmina trial provides the best current available evidence, and we should act accordingly. And upfront cytoreductive surgery is not an option. And if you see the NCCN guidelines, it is also mentioned, yes, if it is low risk, good, take it, but rest, do not offer this. Okay, because it's a considerable disease related scores are there. You have surgical risks, you have problem with irresectability, morbidity, and personal preference. And some of the diseases are quite extensive. Why do you take it out with the thrombus in the renal veins, stuck multiple nodes? Yes, it's a cumbersome task, and you should not do in the era of modern chemotherapy medicines. And if you see, these are some of these studies. Yes, even just giving sunitinib, there was a median overall survival improvement was seen. And I think there are many studies. Now, whether cytoreductive surgery continues to play in future or it's the end of it. But that's the beginning of everything. See the future landscape which is there. And we are getting in the world of immunotherapy, and immunotherapy is already in India, and many of us used. Also, don't forget of the anti-VEGF TKIs. They are also stepping in. Yes, bringing down cytoreductive nephrectomy, a much lower indication than we were doing. We are going for an immune-based, the nivolumab data is it's got approval because of the response rate in these cancers. And yes, reintroduction of immunotherapy in this patient population. And how do we place the cytoreductive? Isn't it losing its importance in these evolving data? Talk about the phase 3 iMotion, which is the atezolizumab. Yes, it has been compared and it shows superior benefit. It got its approval. It's a paramount importance of multimodal approach and patient selection in an era when you have atezolizumab and bevacizumab with you. Do you place it up front, or you think, yes, I will go a little slow? Targeted therapy. You have the cabozantinib study, excellent response, not commonly used cabozantinib, but it show a much improvement and bringing your rates down. So don't you think the future is quite bright? I don't think so. We are debating now, but when the more usage comes, the debate will come down and we will be shrinking. That is not a debatable question. Yes, it is just this patient, do the surgery. Rest is no surgery, no surgery, and no surgery. We have very good line of drugs. And I thank you everybody for listening, and I'm happy to take further questions.
Yeah, thank you, Anita. You have done good job as usual. Now we'll give chance for rebuttal. Probably he will stress on partial nephrectomy.
Sir, I will not stress, sir. Madam even in fact spoke about cytoreductive nephrectomy. Sir, we spoke the same thing. I told Goodrich we should do. Madam also told we should do. She put in the note that in one risk factor there is an advantage. I also told there is an advantage. She never told that you should not do it. The debate was whether we should do it or not do it. I told my point that you should do it in good risk and a subset of intermediate. In fact, in all, maybe if you see not and poor risk, also I showed we should not do it. She said we should not do it. Now, in the era of immunotherapy, in fact, I should thank Amish sir in our discussion. Those patients who had a nephrectomy and then had these IO therapies or IO therapy in relapse, they did better than the upfront IO therapy in the de novo metastatic disease, if you go through that data. So probably at some point, this nephrectomy had helped. And that is what I am trying to tell. I never said we are concerned. Being a medical oncologist, we know how effective these drugs are. But my point is, in a selected patient, you can even avoid these treatments. So if you have a 3 lung met small with a de novo metastatic disease, you can do a nephrectomy and just observe. I'm not telling in every patient. I said you should judiciously choose it. And there are 3 categories where you should choose. A low burden disease, you can observe. Maybe in one risk factor, you have a survival advantage. And I'm talking prospectively as far as Carmina. 2 risk factor, probably a cytoreductive component might have helped in improving the survival. So my point is, cytoreductive nephrectomy will never go away. Yes, you have to be judicious in choosing it, because if saying no to every patient of de novo metastatic lung cancer is a wrong thing. You have to choose it because in a rightly chosen person, even in the IO era, what we have suggested with the indirect evidence of post-nephrectomy survival and de novo metastatic survival, in this, it is better in post-nephrectomy. So this is indirect proof that it will have its own place. Now, not in all, but in a subset of patients, and that subset should be at least 30 to 50% of all the patients. Thank you. Thank you, madam.
Yeah, we cannot have a polling since it is a Zoom meeting. So we'll take it as both of them have done good job in educating us, and we'll now go to the organizers for the next event.
Dr. Sairam, Dr. Poonam is there for expert comments. It was nice debate. Dr. Poonam, we need your expert comment on this.
Yeah, so it was indeed a very good debate with both our senior medical oncology colleagues thumping their points for and against cytoreductive nephrectomy. And as both the sides have told that the role is still being defined, the timing is still being defined, and tumor biology ultimately it is the king, and it will further dictate management. So the tumor, the biology of the tumor, and what treatment we are going to give, whether it is now only IO or IO plus TKI, and nowadays most of the regimes are a combination of both. So we still have to learn what is the best timing of cytoreductive nephrectomy. And there I do agree that there is a role of cytoreductive nephrectomy, but it is both the participants are winners. It's a joint, it's a draw. Thank you very much.
Yes, yeah, thank you, Dr. Poonam. Thank you so much. Nice to see you. Bharat, very good presentation. Thank you.
Thank you, madam.
Our next session is on, speaker is Dr. P. Suresh. He is a senior consultant medical oncologist at RNR Hospital, New Delhi. So he will be speaking on changing treatment landscape in metastatic hormone-sensitive prostate cancer. Dr. Suresh.
Yeah, thank you, Dr. Kumardeep and the organizers for this opportunity day. And is my screen being shown?
Yeah, your screen is visible and you're also seen.
Okay. So then I'll quickly start as we are already late. So hormone sensitive prostate cancer, the definition, like previously we used to call any prostate cancer that was resistant to androgen deprivation therapy as a hormone resistant prostate cancer. But now we know that even after androgen deprivation therapy has failed, the prostate cancer is still sensitive to other hormonal agents, still responsive to other hormonal agents. Hence, we have brought in this term castrate-resistant prostate cancer for those cancers which are still sensitive to other hormonal agents. For 70 years, we have been doing what this gentleman, Dr. Charles Higgins, who won the Nobel Prize in 1966, found out that prostate cancer was highly responsive to hormonal therapy. And that has been the backbone of our therapy for almost 70 years. And even today, when we know that prostate cancer goes past these hormones and becomes hormone resistant or hormone castrate resistant, we still know that the prostate cancer is still often driven by these androgens. And these androgens are being produced in the same prostatic tissue. So many men who have progressed on the primary androgen deprivation therapy, they remain hormone sensitive and are referred to as castrate resistant, as I mentioned. And with the advent of these newer agents, one which blocks the synthesis of the androgens, that is abiraterone, and the other which are the second generation anti-androgen therapy, enzalutamide, apalutamide, and darolutamide. These have changed the way we approach prostate cancer. So the questions in this era would be, what do we do for a rising PSA without evidence of any metastasis? That perhaps is not the actual topic of discussion today. Initial treatment of men with distant metastasis. Now, there can be two instances in this. There can be de novo metastasis versus a later presentation of metastasis after initial therapy. High versus low burden of disease, which is the criteria in many of the trials which you are already aware. And is maximal therapy or combination therapy better than sequential therapy? And is there any role for the concept of intermittent androgen deprivation therapy? And what do we do on disease progression while on therapy? So rising PSA and no overt metastasis, I will just go through this quickly. After local therapy, this is definitely a situation we are considering after the patient has undergone some form of local therapy and has got a rising PSA. Now, with the advent of the PSMA PET scan, these kind of patients are decreasing by the day because these scans can detect even small amount of metastasis. So radiotherapy to the primary site is one of the options that is considered for rising PSA after surgery. And men with slowly rising PSA, now the definition for this has been standardized as a doubling time, PSA doubling time of more than 10 months, or a low PSA, which is less than 10 nanograms per ml. So these are the patients whom we consider as generally not requiring treatment. And there are these new treatments available for the ones who have a rapidly rising PSA. So there are 3 drugs which have been tried in this setting. There are very important trials published in NEJM, as we can see, enzalutamide, apalutamide, and darolutamide. So a summary of all these trials is presented here. The PSA doubling, this is for patients who have a PSA doubling time of less than 10 months and they have no overt metastasis. Primary endpoint in all these trials was metastasis-free survival. A secondary endpoint was overall survival. And we see here that the metastasis-free survival is more than doubled in all these 3 trials. And there was also a trend towards, these are the curves which are separating widely. And these are the overall survival curves in all these 3 trials, the Prosper, Spartan, and the Aramis trial. So there was a 30% reduction in the risk of death, or a hazard ratio of approximately 70.7 in all these 3 trials. So there was a statistically significant improvement in the overall survival also. So when we are going to treat patients with almost no symptoms, but only the PSA, so the side effect profile of these drugs is very important. And as we see here, fatigue is a very important side effect of most of these agents. And fatigue is more common with the apalutamide and enzalutamide and very less with the darolutamide. In fact, most of the side effects are very less in the with darolutamide. So bone fractures, falls, hypertension, these are seen in almost 15 to 20% of the patients on apalutamide and enzalutamide. Seizures are actually very rare, though we always associate enzalutamide with seizures, but it's a very rare occurrence. Rash, weight loss, and hypothyroidism are the other important side effects. So it's a trade-off between side effects and the benefits that are accruing. So can we criticize these 3 trials? I would say that early treatment with these agents with PSA doubling time of less than 10 months definitely improves metastasis-free survival. There is an overall survival benefit. Some may call it a small overall survival benefit. Now, there were certain increased risk of cardiac events in some of these trials. So caution is advised for treating people who have cardiovascular disease. Most importantly, the benefit obtained is at a high financial cost. In India, though, enzalutamide is available generically, but in US and other countries, these are drugs which have a very high cost associated with it. And alternative treatment. So the important thing is that abiraterone has not been used or tried in trials in the same setting. But however, if you extrapolate the evidence of abiraterone from the other settings, we can say that perhaps it will also produce the same effect. So an alternative treatment approach using agents with a more favorable cost-benefit ratio is definitely required. So now we move on to the next setting, which is the initial treatment of metastatic prostate cancer. So we have 3 agents here, 3 or rather 4 agents: docetaxel, abiraterone, and enzalutamide and apalutamide. So all these 3 agents, the clinical trials, phase 3 important clinical trials have shown that there is improved survival when any of these agents are added to androgen deprivation therapy. So we will address a few questions now. Who benefits or who does not benefit, and is the concurrent treatment always better than sequential? And as mentioned previously, is there any role for intermittent ADT at all? So docetaxel, we know very well the Stampede, Chartered, the J2 trials, all 3 trials have consistently proven that docetaxel improves failure-free survival as well as overall survival conclusively. So there is no doubt on this point. Now, the important thing would be that the patients treated in these trials, Chartered and Stampede, may not reflect the population of patients who are presenting to us most of the times, especially the ones with metastasis years after diagnosis. So in these trials, almost 70 to 90% had metastatic disease at diagnosis. The median age was 64. And almost 67% had high volume disease. So this is a concept here. There are 2 concepts: high volume disease and high risk disease. So high volume disease is again defined as bone metastasis more than 3 or more than 4, and with 1 metastasis which is in the appendicular skeleton rather than the axial skeleton. Any visceral metastasis is considered as a high risk disease or a high volume disease. And almost 67% of the patients had a Gleason score of 8 to 10. So there will always be a group of patients who have lower grade cancers and who have developed metastasis after a long time of the initial diagnosis, who may not benefit with this kind of aggressive therapy. So there was a pre-planned but underpowered subgroup analysis in these trials, and as we see here, the docetaxel with ADT benefited the patients most with high volume disease with a hazard ratio of 0.63, and in the low volume disease patients there was no actual benefit. So addition of docetaxel in the Stampede trial also, so that was in the Chartered trial. Now in the Stampede trial also, docetaxel showed benefit, but again it was much less compared to the Chartered trial. So should men with low volume disease receive docetaxel plus androgen deprivation therapy? There is no doubt about high volume disease that they should receive. But from the Chartered trial and the Stampede trial, if we make a conclusion, I would say that men with low volume disease should not receive docetaxel based therapy. Now we have a similar data with abiraterone when added to androgen deprivation therapy for high risk advanced hormone sensitive prostate cancer. Now there are minor differences in the definition of risk in these trials. So Gleason score, visceral metastasis, and number of bone lesions. These are the usual criteria that are used to define high-risk disease. And we see here that androgen deprivation therapy with abiraterone improves
We are not able to hear you.
Hello, Dr. Suresh. Hello, Dr. Suresh. We are not able to hear you. I think Dr. P. Suresh has gone due to network problem.
Can we proceed for the next session?
Yes, sir. Yes, sir.
I think we should. Sairam sir, can you call Dr. Can you call for the moderator for the next session? Dr. Amish is there.
Yeah. Yeah. Dr. Amish, can you moderate the next question and call your you can call your panelists, Amish, and start away. Start because we are, I think, we're running late. Amish, you can call your panelists and start away. Start. We are not able to hear, Amish.
Dr. Amish, please unmute.
Amish, you are there? We are able to see your screen, but we are not able to see you nor we cannot hear you.
Ravinder.
So we are calling.
Yeah. Hello, Ravinder. Sunidhi, are you here?
Yes, sir. We are calling Dr. Amish.
Oh, no, his slide is jammed, so you can share slide from your side.
Yes, yes, sir.
Right.
Okay. Yeah. Sorry. Am I audible now?
Yeah, yeah. You're audible and visible also.
Okay, perfect. Thank you so much. Sorry, my laptop is notorious for getting freezed. Especially जब कुमारदीप को देखता हूँ तो थोड़ा मैं डर जाता हूँ. So my panelists, can we have the next slide? My panelists are Dr. Safalta Bagmar, Dr. Deepak Abrol, Dr. Rajat Bajaj, Dr. Varun Goyal, Dr. Mithun Chako, Dr. Novak Gupta, and Dr. Kshitish Domadia. How many of us are there? Do we have Dr. Safalta?
Safalta is not there.
So Dr. Safalta and Dr. Deepak, they both are not there, or others are there, sir.
Others are there. So other 5 doctors are there. Thank you so much. I think in 25 minutes, 5 panelists would make a good sense. Can I have the next slide, please? Okay, so my topic is supposed to be a case-based discussion. I will just start with my case, a very interesting one. 61-year-old male, In 2013, he was diagnosed with RCC on the right side. The right nephrectomy was done and the HPR was G2PT1B. There was no news on the lymph nodes and MX. No adjuvant treatment was given. Next slide, please. So Dr. Rajat, I would like to start with you. In 2021, would you have offered adjuvant pembrolizumab to this patient based on Keynote 564? Dr. Rajat?
Sir, I think he is also not there.
Okay. Dr. Varun?
Sir, till now, like we haven't offered any adjuvant treatment like in form of IO agent for a RCC patient. So, data is still maturing, I may say. So I will wait for some more maturing of data and guide.
We'll wait for some more. Dr. Mithun, I saw him also. Dr. Mithun, ASCO 2021 had a very interesting data on Keynote 564. Can I have my next slide, please? Dr. Mithun, hazard ratio of 0.68. And if you see, there were 22 versus 30% events already happened as compared to placebo. Dr. Mithun, if the patient is affording and patient is high risk, instead of PT1, say PT3 with grade 5, would you offer pembrolizumab in these patients? I saw Dr. Mithun. Okay, Dr. Novak, do we have Dr. Novak?
Yes, sir. Sir, good evening.
Good evening.
So I think the adjuvant pembro data recently we've seen we are seeing a good DFS benefit. Yeah, maybe I guess in case the patient was presented to us today, maybe we could offer this the adjuvant pembrolizumab to this patient now, but not in 2013.
No, I'm talking of 2021. If this patient would have come with high-risk features in adjuvant setting, would you have offered pembrolizumab?
I might. This was a kind of it was just T1B, but maybe
no, I'm talking of PT3 N0 with grade 4, grade 5, some sarcomatoid differentiation. These were the inclusion criteria in Keynote 564.
Yeah, then definitely.
Then definitely. Dr. Kshitish, do we have Dr. Kshitish?
Yes. Good evening, sir. I'm there, sir.
Good evening,
So,
Dr. Kshitish. With you.
Right, sir. So till now, I haven't offered any adjuvant pembrolizumab for my patients. This data seems impressive, but still, sir, I would like to wait for more maturation of this data. This is a 2-year DFS rate. I would like to see more of OS data coming, and after that, I think perhaps I'll be more inclined in using this, but not at this moment, sir.
Not at this point, Dr. Kshitish. Dr. Kumardeep, the main organizer, would you offer adjuvant pembrolizumab in these patients? And Dr. Kshitish says that in adjuvant setting, he would wait for OS data. Would you wait for OS data and would you offer pembrolizumab in 2021 in high-risk adjuvant setting?
Sir, at this moment, I have not offered adjuvant pembro to
neither any one of us. This is the recent data, just 2 months old data. If the patient comes tomorrow to you with node positive RCC, some sarcomatoid differentiation, a complete resection has been done, and based on this data, would you offer adjuvant pembrolizumab?
Not at this point. I'm not comfortable till more mature data comes.
What do you mean by more mature data?
OS advantage.
OS advantage.
Right.
Okay. So everybody agrees that unless and until OS advantage is there in adjuvant setting, we would not offer in pembrolizumab. And in fact, this is very interesting. We had a very interesting discussion about the adjuvant olaparib in BRCA positive breast cancer, where Dr. Sudeep Gupta was of the opinion that he would not wait for OS data, but if there is a significant PFS advantage, he would offer in adjuvant setting. But that is again a point of discussion. I just wanted to highlight that this particular aspect can be a practice changing in very, very recent future. Next slide, please. So this was the OS data, what they had shown. And based on this, although the hazard ratio was 0.54 and the p-value was 0.0164, although it was not crossing the line of significance. I see Dr. Mithun Chako coming back again. Dr. Mithun,
Yes,
we missed you. I saw your face, but I couldn't then this thing. Would you offer pembrolizumab in 2021 in high-risk adjuvant setting?
If the patient is willing and they are knowing the pros and cons, I think we can offer, because we have got data at least. Yeah. If the patient is willing to afford the cost.
Okay. So there we have a house divided, and the panelists are completely divided. Some would want to wait for OS, and the two of the panelists said that they would offer adjuvant. As regards IGO, there is a significant PFS advantage, especially in a high-risk patient where we have nothing else to offer. I would discuss with patient and talk to them about the pros and cons of IO therapy. This is one of the things in our armamentarium. Next slide, please. So the other two panelists, they were right. NCCN version 1 2022 have not included pembrolizumab in adjuvant setting in any of the stage. And I think they are also waiting, like Dr. Kumardeep and other panelists said, about the more so-called mature data. Next slide, please. So our case, 2013 to 2016 was on follow-up. Of course, there was no adjuvant at that point of time. In 2016, he presented with epistaxis and pain in nose. MRI showed there was a sinonasal growth of 1.5 by 2 centimeter. Biopsy from this showed RCC. PET CT, there was left side kidney lesion also of 2.5 by 1.5 centimeter. What next? Bharat has written a note in the chat box. Bharat, can I ask you your opinion? Dr. Bharat Vaswani, please unmute yourself.
Sir, if you see that population around, we need to understand, if we don't treat it, what is the chance of recurrence? T1B, T2, probably the recurrence chance are 20 to 30. The moment you say T3, T4, it becomes 30 to 40%. But two subset of patients, lymph node positive and a metastatic disease which was treated, because in total these were 18% patient, if you remember. There the chance of recurrence is 60 to 80%. I think so. Probably in those subsets, we should start thinking of it, because 80% recurrence in the treated
agree. Bharat, I completely agree with IO of your observation and points absolutely well taken. What I am asking is, after 3 years, sinonasal mass and 2 centimeter mass in the opposite kidney, what would you do next?
Sir, partial nephrectomy is an option when it is less than 4 centimeter. So less
than 2 centimeter. What about the sinonasal mass?
So I probably will do a biopsy, sir. First, let me.
Biopsy proven RCC. It was in fact an excision biopsy done through endoscopy by ENT surgeon.
Sir, then think of giving starting a treatment, systemic therapy, because it is already a metastatic disease. But sir, definitely, suppose if both are resectable, I may even think of that also. So if it is an isolated sinonasal mass and a 2 centimeter thing, probably if it is resectable, I may undergo a partial nephrectomy with a complete excision of a sinonasal mass, if feasible. And if there is no other metastasis.
Dr. Kshitij, would you agree with Bharat, or would you like to do something else in this patient? Dr. Kshitij. Kshitij, you have to unmute yourself.
Yes, sir. Yes, sir. So this patient is having a left kidney lesion of about 2 centimeter and a sinonasal growth. Okay, so definitely I would like to do a nephrectomy, partial nephrectomy, definitely. A partial nephrectomy, put the patient on a systemic treatment. Yes, definitely.
Okay, perfect. Dr. Mithun, excision biopsy of sinonasal mass has been done. So the only thing that is left behind is a 2 centimeter mass in kidney. Would you agree with Kshitij and Bharat?
Yeah, if partial nephrectomy is possible, definitely go ahead with partial nephrectomy.
Partial nephrectomy
there is no other disease, I think we'll have to go ahead with the surgery.
We have to go with surgery. Dr. Novak.
So honestly, it's a kind of very tricky situation. I think if he's undergone excisional biopsy of the sinonasal mass, maybe I would advise to go ahead with the partial nephrectomy now.
Partial nephrectomy now. Okay. Next slide, please. Patient didn't like India, so went abroad. And there's a real case right now taking treatment under me. And the discussion somewhere was asymptomatic metastatic RCC and the treatment. Dr. Kumardeep, does this asymptomatic metastatic RCC 4 years later, one met already excised and other met asymptomatic? Does anything, will anything different go in your mind? Kumardeep, you have to unmute yourself.
Wait and watch is one option. So we can look for the speed of the growth. And if the patient is asymptomatic, I'm assuming that number of metastatic disease is not very
This patient is asymptomatic, completely asymptomatic. And Kumardeep, you have really struck the chord. Next slide, please. This patient was offered surveillance, but before that, in 2021, I would like Dr. Varun to answer that question. Dr. Varun was the first one who answered. Dr. Varun, do we really need to follow IMDC criteria or any of these good risk, intermediate, and high risk, assuming that Dr. Bharat and Dr. Anita have already sorted out issue of cytoreductive nephrectomy? Do we really require this classification in 2021? Dr. Varun?
Yes, sir. Sir, I think we should do risk stratification of our patient. Like, because if our patient is like low burden disease and good risk, we can still offer TKI. It's not like that every patient should offer IO agents. So if intermediate or low risk patient, we can offer IO or IO TKI, but in good risk, we can still offer TKI only.
Okay, Varun, NCCN guideline does not somehow agree with you and me. I agree with your point. Why I ask this question is that you take IO plus TKI. All the combinations are approved in good, intermediate, and high risk metastatic RCC. So the question is that, really it makes a huge difference. But in this particular patient, it makes a difference, and we'll see why. Next slide, please. Okay, so active surveillance. Many retrospective data have shown that in an asymptomatic metastatic RCC, in our case, which has progressed 3 years after the last surgery, makes sense. Next slide, please. And we have the prospective data of this particular registry where they did a prospective randomization, means it was a physician's choice whether to offer any active treatment or surveillance. Next slide, please. And what they found was there was a huge OS benefit between the two. Although this particular is an observational prospective registry, it is very, very difficult for me to believe this particular data where 122 months versus 30 months. But the point was taken was that in an asymptomatic patient with a good risk MRCC, active surveillance as shown by or as suggested by Dr. Kumardeep is not a bad option, which we always forget in our clinical practice. Next slide, please. So this particular patient, next slide, please. This particular patient underwent active surveillance. Can I have the next slide, please? 4 years patient was asymptomatic. After on active surveillance, once a year, he used to go abroad in one of the top-notch institutes, which we all know about, till March 2021, when he started having fever and some low hemoglobin. He again went abroad. There was low hemoglobin of 7.4 found and low-grade fever for last 20-25 days. CT scan thorax showed some lung nodules. Okay, Dr. Mithun, now what would you do? Patient underwent surgery, followed by observation, followed by metastasis, followed by excision biopsy, followed by surveillance. So you are 8 years down the line after the diagnosis of RCC.
Sir, his left renal lesion was not addressed, right?
left renal region was not addressed. It was just an excisional biopsy of sinonasal mass and observation.
Okay. Now what is the present status now? Has a PET been done? No. PET CT?
There was no PET CT done in US, and neither did they give me any CD also. All I have is a detailed 5 pages note every time patient went to OPD. In that, there were lung nodules in the CT scan thorax. FNAC from one of the lung nodules showed RCC. There is active disease in the left kidney still there. Along with that, there are lung nodules and patient is symptomatic now.
Yeah, right now symptomatic. So definitely systemic treatment is required. And if the patient is willing, I will go ahead with IO plus TKI if possible.
IO plus TKI. I think there is no brainer that this patient requires symptomatic treatment now. Next slide, please. Okay, so this is what I was talking, and Kshitij, I would like to ask you, if you see, sunitinib is not seen anywhere in this NCCN guidelines, and I wonder where is sunitinib gone. Bharat and Anita ma'am were discussing about CN versus sunitinib, and there is no sunitinib seen here. Kshitij, what do you do in your clinical practice now?
Sir, 90% of my patients take sunitinib, and I think this is true for most of us.
So true, so true. We talk of IO and hearing the cost, they run away anyway from us.
Yes,
exactly. So true, Kshitij. Dr. Novak, in your practice, have you given up on sunitinib and you offer always these options?
So, my hands are limited. I am kind of bound to use a Nivo, Pazopanib, and sunitinib. So the other options are kind of restricted to me. So I have to in these three.
Okay. Dr. Varun? Dr. Varun, what do you do in your practice?
So obviously, I will counsel all the regarding all the options. And if patient is affordable, and then I will go ahead with the IO plus TKI. But as other my colleagues are saying, that most of the patients do not afford, and most of the patients just take either sunitinib or pazopanib.
Okay, sunitinib or pazopanib is still there in India. Dr. Kumardeep, you are a rich man medical oncologist. You don't have an option of giving me answer of sunitinib. What is your option? Dr. Kumardeep.
I can answer like exitinib. If you are not giving any option, then exitinib or pembrolizumab. But practically speaking, for my practice, good PS, sunitinib, bad PS, pazopanib. That is the 90, almost 100% of the patients are like this. And pembro.
Okay. I get your point.
Yeah. And
Kumardeep, I get your point. Right. I just wanted to highlight. Yes, Kumardeep. Sorry, go ahead.
Pembro, I think everyone will agree with me that Pembro, Nivo, and all these things, mainly these are being CGHS, CCHS patients are getting this in our practice. I don't know, you are practicing in South Delhi, maybe your clientele are different, but we have to deal with this kind of patients only. So hardly any cash patient.
I agree with you. The thing is that I think what I wanted to highlight here is that I think the best data what we have so far in terms of hazard ratio is with lenvatinib plus pembrolizumab, and the second best data in terms of hazard ratio is with cabozantinib plus nivolumab. Exitinib plus pembrolizumab in favorable risk is on the lower on the cards. In fact, a good risk patient, exitinib plus evolumab, the data is coming up in a very good way. In fact, that can be one of the options which will come in the future. But right now, in terms of hazard ratio, I think Lenva plus Pembro scores a lot. I also have few of my patients who can afford IO, around 10% of patients. 90% of patients, we offer sunitinib, or lately I have started offering cabozantinib, which is easily available and it is cheaper option. Next slide, please, if it is high risk.
Sir, I have a question.
Yes.
Yeah. What is the tolerability profile of those Lenva plus IO? How are they
Lenva plus
tolerated?
pembrolizumab, I was lucky, Kumardeep, in last 3-4 months. As I said, I was lucky. I'm saying that. Please don't think that those are the profile of my patients. In HCC and in RCC, in last 6 months, 4 patients I have used Lenva plus pembro and reduced doses of Lenva. They all tolerate, and all 4 of have done well so far. It is just very early time, but they have done well. So this patient was
to
offered,
add this, just to add this, we also have a few of our patients with pembro plus one is XC, one is Lenva, and this Nivo AP. So most of the patients, there is no issue with tolerability. Like if we monitor them well, so the tolerance is okay. The problem is
excellent.
financial.
Thank you. That's great. We have financial toxicity, which we will discuss some other time. So this patient, of course, as you know, could go abroad every month, every second month. So he was given Nivo plus cabozantinib option. After 4 doses of Nivo, he complained of palpitation, nervousness, irritability, and insomnia. There were some skin changes also and some nail changes also. You can call it as one of the TKI-induced skin nail changes. Dr. Novak, what would you think here?
So I think the skin changes and the nail changes is probably because of the TKI, the palpitations and nervous. You know, I need to see. He was on Cabo. I'm not sure, sir.
He was on Cabo, not sure. Dr. Kshitij, you have put something about Nivo AP versus Pembro XZ. We will discuss that. But right now in this patient complains of palpitation, nervousness, irritability and insomnia. Patient says, sir, 3 रात तक नींद नहीं आती है, कितना भी मतलब नींद का दवाई ले लो. What would you think in this patient?
Sir, I would like to think in terms of any immune-related adverse events who are
Correct,
complete,
you are right.
Complete endocrinological profile, ACTH, cortisol, thyroid function test. So think in terms of that, because this is after 4 doses. So maybe the timeline of immune-related adverse events, I can think in that direction.
Okay. Any particular, Dr. Mithun, because why I mentioned after 4 doses, because it's exactly after 4 doses. Any particular immune-related adverse events which you would see so early, after 2 to 4 doses? Yes, Dr. Bharat has put it in the chess box. Dr. Bharat, you are an intelligent man and you are right. Next slide, please. Okay, so TSH was 0.01. I didn't have the T4, but T4 was raised. Patient's pulse was 122. Holter was done. There was no arrhythmia, echo, which was normal. Next slide, please. So in thyrotoxicosis, when would you, Dr. Varun, when do you stop immunotherapy, or have you seen hyperthyroidism? This was my first case of hyperthyroidism post-IO. We all see a lot of hypo, but this was hyper. Dr. Varun, your personal experience.
Most of our cases also, if they have some thyroid abnormality, most of the time it is hypothyroidism. I also haven't seen any hyperthyroidism, but I think after symptomatic management, maybe 1 or 2 weeks we can delay. After that, we can continue.
1 or 2 weeks we can delay. So here it says that continue immunotherapy if asymptomatic, but patient was symptomatic, right? So what you are saying is right. Dr. Mithun, would you stop immunotherapy or would you give propranolol 10, 20 mg and just go ahead with immunotherapy? Dr. Mithun, do we have Dr. Mithun or we have again lost him? Okay. Dr. Kumardeep, would you continue immunotherapy or would you stop? Would you wait for hyper to become hypo?
We can, because the patient is symptomatic, so we can stop the therapy for a couple of weeks, because usually we repeat thyroid function test in 6 weeks times, because if we do any change of drug, it is not reflective on the thyroid function test before 6 weeks. So ideally we should, and it should not be repeated before 4 weeks. So we cannot stop the treatment for 4 weeks. So ideally we can wait for a week or so, start with the propranolol. Propranolol will show effect in 5 half-life, that is almost 4 to 5 days time. So, and then after that, we can start the treatment because the patient had tachycardia, for which patient is symptomatic. So propranolol will take care of that. And then, but probably thyrotoxicosis is harbinger of hypothyroidism. In 4 weeks time, we have to repeat the thyroid function test. So that way we have to follow.
Kumardeep, you are absolutely right. Your timelines are also so perfect. I'm so proud of you. Next slide, please. Patient was started on propranolol. Can I have next slide, please? Patient was started on propranolol. Symptoms exactly subsided in 4 days' time, as Kumardeep had said. After 7 days, we continued immunotherapy. Since we are running short of time, 60 to 90% of patients with hyperthyroidism develop hypo after 6 to 8 weeks, and that is what exactly in this patient happened. Next slide, please. Yes, so this was transient thyrotoxicosis during nivolumab. 2020 onwards, it has started. Next slide, please. Yes, Bharat, you are right. Hypo is more common in PD-L1 inhibitors. This was one particular article from Japan I saw in 200 patients, out of which they said that there were 61 patients who developed thyroid-related immune adverse events, and all those did better compared to those who did not have any thyroid-related adverse events. And this was one paper. Next slide, please. So our patient settled down. First scan showed partial response. The lung nodules reduced and regressed in size. The kidney nodule was almost unseen. Total 7 months of treatment with nivo-carbo done. Patient came for the next dose of nivolumab, and this patient was found to have herpetic lesions. Now, again, this is a real patient who's taking treatment under me, and this would be our last discussion point for today. I couldn't find any data. That's why I'm asking all the panelists, and let's start with Dr. Bharat Vaswani, because he is the most knowledgeable amongst all those whom we have right now. Bharat, if you are still there, would you stop immunotherapy? How long? Or have you seen herpetic lesions with IO drugs?
Sir, I have not seen it, but I will stop it for the time in whether it is probably 2 weeks, sir, maximum 2 weeks, because by the time second week you will have that black scabbing come. So I'll stop it for the time being. Do we have a data? I'm not sure, sir, to be frank. But yes, in terms of any acute things, probably this, I will stop it for 2 weeks, not more than 2 weeks, until we get a scabbing, sir.
Okay, Dr. Novak, what would you do?
So I personally, I do not have I've not experienced, but I think I would fully agree. The patient is, in case the patient has developed herpetic lesions, I would want to stop the nivolumab.
You would want to stop. Dr. Kshitij?
Yes, sir. Stop nivolumab, treat the herpes first, then give another dose.
Okay, Dr. Varun, I told patient like everyone that I will stop nivolumab. I will not give you nivolumab today. He said that my US doctor have said that you start with ganciclovir or acivir, but you continue immunotherapy. What would I do in such situation, Dr. Varun?
I also don't have any any of my patient. So, but still, I would counsel him to hold for at least 1 week or 10 days. And after that, I will go ahead.
After that, you go ahead. I told my patient exactly the same. I agree with all of you. And I told my patient that, okay, look, I'm not going to start. I could find 7 case reports in 2020 itself that herpetic lesions were developed on IO, and everybody stopped. As Bharat said, till the scabs are formed on the herpetic lesions, they are no longer any infective, and then we started on immunotherapy. I just wanted to highlight these 2 immune-related adverse events in this case, and also the importance of active surveillance in this particular case. Next slide, and the summary of this thing is, this patient had a localized disease to begin with, relapsed after 4 years. It's a good risk. Asymptomatic relapse, 4 years on surveillance, which is a very, very good thing. Cabo-nivo was given, which is again a hazard ratio of 0.48, and which is a good choice. Patient had thyrotoxicosis followed by hypothyroidism and herpes on immunotherapy, both settled down. 8 months as already With this, I hand over the mic and giving your viewpoints. Thank you so much, Kumardeep.
Excellent panel, sir. Excellent panel discussion. You are a very good teacher, sir.
Yes, yes.
Bharat, you always say that, and that makes my day, huh?
No, you are a best
Whether
teacher,
it is
sir.
right or
The
wrong.
best. Everybody will agree. Best teacher.
Yes. We all agree, sir. Like excellent.
Thank you so much, all of you. And thank you, Kumardeep, for inviting me.
Thank you all. Thank you. Special thanks to Amish Bora sir and Dr. Bharat, because they are the best presenter of the evening. Dr. Sairam sir, because they had taken a lot of time of busy schedule. And thank you all panelists. Thank you speakers and attendees. And